be done, and what are the factors we should consider in patient safety while managing the patient. So this is a complete CME regarding the laser in proctology. And the first talk was supposed to taken by Dr. Nitish sir, but is on the way. So I have started the second lecture. So these are all the machines which we can use in proctology, different companies. This is 1470 nanometer diode machines. The technical aspect of all the machines may be different, but basic principle remains same. And user manuals of all these machine may be some difference. પાછળ સંભળાય છે બધાને? Okay, okay. So goal when you manage the patient with the minimal invasive surgery to treat as less invasive as possible with minimum risk to patient. This minimum risk to patient comes when you apply the right technology in the right patient with the right indication. So choose the right patient and master your technique to use the minimal invasive surgery. So laser is a light amplification by stimulated emission of radiation. So laser energy is very potent energy. It is very precise, and when it is used very wisely, it gives wonderful result. Training before using laser machine is must. So get yourself trained from training from the experts, attending conference and CMEs, watching good surgical videos, and reading some good books. Owing laser does not make one a laser surgeon. Hence, one must master how to use the technology of laser. So get yourself trained. First, few surgery you watch and observe. Then few surgery you assist with the expert. And then start independently doing the surgery. Similar as in other surgery learning curve. Why we choose 1470 nanometer wavelength machine? Because a wavelength of 1470 is more efficient and it works under waterized medium. 1470 is 60 times more effective than 980 machine. More anal pain is reported when using 980 machine as compared to 1470. And margin of safety is more with 1470 because depth of penetration is more and potency is high. While setting the laser machine, we have to look some important parameters like how much energy you are giving in a single pulse, how much the pulse duration, energy density, frequency, and output power. So in machine setting, you set the watt of the machine, that is from 6 to 10. Uh, 7 to 8 watt is used in 6, 7, 8 watt is used in piles, and 10 watt is used in fistula and pulmonary sinus. And in Fisher, you use the 10 watt. Then continuous or pulse mode. So in continuous mode, the energy is delivered throughout the when you press the laser machine key, foot switch. And in pulse mode, it is given in the pulsatile manner. Then how much is the pulse duration, pulse time, and acoustic light? Acoustic light is a laser light which come out from the tip of the laser fiber. So in proctology, we apply the laser for the laser hemorrhoidoplasty. The good patient are first degree, second degree, and third degree piles are good indication for the laser. Large fourth degree piles, gangrenous piles, prolapsed, too much external component. These are the patients which are not very suitable for the laser hemorrhoidoplasty. In pylonal sinus, Valapse can be done, that is video assisted laser ablation of pylonal sinus. And EPSIT, that is endoscopic pylonal sinus treatment. In this also we use the laser to ablate the sinus tract along with other surgical procedure like pit excision and excision of the extra opening. In anal fissure, the laser internal sphincterotomy can be done without putting a incision with the minor puncture wound. The other methods are open internal sphincterotomy. So results of both laser and open in case of fissure are almost similar, but you can avoid the wound when you use the laser. So wound complication can be minimized. In fistula, there is a fistula laser closure and distal ligation with proximal laser, and it can be used with the lift procedure as a hybrid procedure in fistula, is a sphincter saving procedure. So these are the different types of fibers used for the different procedure. Bare tip fiber is used for fissure, fistula, and extra hemorrhoids. It is bare fiber is basically for cutting the tissue and maintaining hemostasis by spraying laser energy 1 millimeter away from the tissue. So basic two function, it is cutting and sometimes you can coagulate the laser bed with the bare laser fiber little away from the tissue. With the pointed conical shaped glass tip. So this is used for hemorrhoids, and sharp glass tip enable easy insertion into the pile mass. Radial fiber with round glass tip for fistula and final sinus. The radial pattern ensure uniform elimination of 360-degree single or multiple rings in all directions. So when you use radial fiber, it delivers energy in a circular manner. So it will coagulate the circumference wall of the sinus and fistula. So these are the safety protocols we use for the ourselves, for the staff, patient, and machine. Use special goggles to prevent light from entering the retina. Doctor and their assistant should wear the protective glass as to prevent laser energy entering into the your eyes. Sometimes accidentally the fiber direction is on your face or on your eye, and accidentally you press the foot switch. So as to prevent the damage, you wear the protective goggles. Uh, Simply light doesn't cause damage, but if the direction is towards the eye, then can cause the damage. Prevent thermal damage to the tissue by cooling it with ice cold saline or ice finger. So you make a ice finger and put a normal saline in the freeze, and at the time of surgery, you use it for the irrigation and uh, cooling of the tissue to prevent thermal damage. Protect laser machine from the damage and fall, and use voltage stabilizer whenever there is a too much of voltage fluctuation in uh, electricity. In laser hemorrhoidoplasty, the overall dose of laser energy should not exceed 150 to 200 joule per hemorrhoidal mass. So, in piles, we use the finger guided hemorrhoidal artery ligation. That is first step, and second time we use the laser. So, first step is ligation of the artery. By doing ligation of artery, you can there is a mild reduction in the size of pile mass. And after applying laser, there is again mild reduction in the pile. There is a shrinkage of the pile. But on table, you don't have to wait till the complete shrinkage of the pile, because cause to achieving the shrinkage of the pile mass, if you give more and more energy, then that will cause tissue necrosis and mucosal damage. So at one piles, the energy should not exceed 150 to 200 joules in a single node. So the mode is used pulse mode, and at the time of fiber insertion, you use 6 volt 1 second pulse, and at the time of fiber activation, use 6 volt 3 second pulse. Fiber is a conical fiber, shaft tip conical laser fiber, and pulse mode it is used. And post operatively after immediately after applying the laser, you cool down the area mucosa by the applying ice finger. The dose is calculated watt into time in second, it is equal to joule. So when you start the machine will automatically shows the joules, how much joules is applied. So while doing piles, your one staff continuously watch the machine and speak the joules loudly, like 7, 14, 28, 64, 90, so that you can have idea that you have used up to 150 joules, and then you can stop the uh, applying the laser energy. Otherwise, you can exceed the maximum dose. So one staff continuously watch the machine and speaks the how much joule is used. So this is the point of entry in laser hemorrhoplasty. The point of entry can be should be at mucocutaneous junction. It is at the white line of Hilton. Enter the fiber from that area and remain in submucosa. Uh, Entering from the dented line has no advantage. So enter from the white line of Hilton, that is mucocutaneous junction, and enter the fiber in a straight line. Apply the energy in a pen-shaped manner. So first in the straight line, then 30-degree upward and 30-degree downward, so as to cover all area of the piles. The fiber should not be too superficial or too deep. If the fiber is too superficial, then light will be very illuminated from the mucosa. So that is very near the mucosa. So that can damage the mucosa and puncture the mucosa. So remain in submucosa. And if the energy is very deep, fiber is very deep, then the light visible from the mucosa will be very dull. So it can damage the internal sphincter. So remain in submucosa. And at the end of procedure, cooling of the tissue is done with the ice finger. In pyloric sinus is cavity or tract in the sacropoccygeal region caused by recurring infection and persistent inflammation. Pyloric sinus develop due to entry of air through the primary opening, that is called as pit. So we have to excise the all midline pits if the skin punch. So primary reason for the development of pyloric sinus is midline pit. So we have to address the pit. Minimal invasive surgery like endoscopic pyloric sinus treatment, EPSIT, and video-assisted laser ablation of pyloric sinus, that is VELAP, have gained popularity because of less morbidity. Pit picking combined with VELAPs give good result with a low recurrence. So in laser ablation of pyloric sinus, first step is to excise the midline pits with the skin punch corset, and then excise the extra opening, then scoop out the sinus tract, give the saline wash, and then apply the laser energy as to ablate the remaining tract and few hairs that are remaining in the sinus that can also be burned by the laser energy. So dosage is energy delivered depend on the length of tract. Radial fiber, 360 degree radial fiber is used. The machine mode is 10 watt setting per millimeter per second in continuous mode. So it is at 100 joules is delivered per centimeter of the tract. In sinus and fistula, we are not too much bothered about the dose of energy, but we have to totally ablate the sinus tract. So roughly you give 100 to 200 joules per centimeter of the tract, so that will be sufficient. So it is if you withdraw 1 centimeter, then it will deliver 100 joules per centimeter of the tract. And at the end, cooling of operated area is by cold saline irrigation with the syringe. A laser ablation of PNS, how to avoid skip areas. So if you withdraw the fiber very rapidly, then there will be skip area. The required dosage should not be given in pulse mode. Do not keep on withdrawing fiber every 5 mm. It will lead to skipping areas of unhealthy irrigation tissue, leading to high recurrence rate. So to prevent skip areas, we have to withdraw fiber very slowly, and sometimes you can repeat the laser ablation within the same track after giving a cold saline wash. In fistula we have to address internal opening, we have to address the fistula tract and external opening. So, while using laser or any minimal invasive surgery, disconnect the fistula tract from the internal opening by the ligation of intersphincteric tract or by the slot procedure. So that will address the internal opening at the intersphincteric level. After the ligation of the tract, you apply the laser energy within the fistula tract and excise the extra opening. So curate well before and after laser ablation. Dose is 100 joule per centimeter of the tract, similar to pyloric sinus. Fiber is same, 360 degree radial fiber. 12 millimeter per second continuous mode. Post-operatively, again cooling of area by the cold saline. So in fistula, for the long fistula tract, this can be used at the adjuvant to lift procedure, that is then DLPS, that is distal ligation and proximal slot procedure. Slot and lift procedure are basically to disconnect the internal opening. In fissure, laser intersphincterotomy can be done with the bare laser fiber. The energy watt is 10 watt continuous mode and cooling of area is by ice pack. So enter the first you infiltrate the saline with adrenaline at the anodome area to elevate the anodome and mucosa from the intersphincter is to prevent mucosal damage with the fiber. Entry of fiber is intersphincteric groove and intra-anal sphincter is divided below the dentate line with the bare laser fiber, and care is taken not to damage external sphincter and mucosa. So remaining submucosa and submucosal plane and incise only internal sphincter, and care is taken to prevent mucosa and internal sphincter. So these are the machine setting for the all the procedures. So we have seen this all the setting, but in case of piles, sometime it can be used by 6 to 8 watt depending on the size of pile mass, and sometimes you can use the continuous mode also. In fissure, avoid repetition if can't cut the sphincter, otherwise it will damage the normal tissue. And in pyloric sinus and fistula, it can be repeated to avoid skip areas and remaining tract. So post-operative protocols after doing perineal surgery, antibiotics, how to use pre and post-op IV ceftriaxone, that is third generation cephalosporin, and IV metrozine. So 1 or 2 dose is required, one pre-operative and one post-operative dose is all that is required. We have stopped using oral antibiotics in almost all cases of the perineal cases, except immunocompromised patient and if there is active infection. Otherwise, we have stopped using oral antibiotics. Only pre-op and post-op one dose is required of third generation cephalosporin and metrozine or tinidazole. Ice pack incision on table, and it can be removed in the recovery room before shifting the patient in the ward. Laxative used are polyethylene glycol and lactulose. This has to be used till the complete healing is achieved for 1 to 1.5 months. Analgesia use the round-the-clock paracetamol and diclofenac in form of tablet and suppositories at 4-hour interval as to make patient pain-free. And sometimes you can use tramadol combination also. Tramadol and paracetamol combination are mostly used in old age patient where you have renal compromised and other medical condition where you cannot use the NSAIDs. SIDS bath twice in a day to be started after 24 hours of the surgery, because in laser procedure there is a thermal time is required to
Last minute, sir.
Yes, I'm finishing. Flavonoids, that is MPFF, used in the piles for post-operative recovery, that increase the venous return and lymphatic drainage, as it help in regression of the piles. It can be given for the 2 months. Topical ointment, that is sucralfate, metrogyl and lignocaine as antiseptic ointment, and cold saline wash or normal saline wash, not cold saline. NS wash with syringe in pylorus sinus and fistula cases post-operatively. So how to clean the fiber tip? So if there is a chairing over the fiber tip, the energy will be less. So removing chaired layer on the tip of laser using wet gauze is necessary. Chaired tissue raise the temperature of tissue resulting in overheating. So remove it with gauze, soak in the saline with hydrogen peroxide, and clean from tips toward the shaft, so as to prevent the tip damage. These are the how to make the ice finger. Take a examination gloves and make a ice finger, put it in the freezer and use at the time of surgery after soaking it in betadine. This is how to check the fiber damage. Look for the pattern of the laser beam, look for the damage at the tip of fiber, and look for the damage in the fiber sheath or shaft. So if the tip is damaged, then don't use the fiber and change the fiber. How many times laser fiber can be used? It depends on the equipment you use. Ideally, fiber are for single use. Check aiming beam pattern and tip damage, and check the fiber tip for any damage. And if there is any damage, then discard the fiber and take a new one. If the cap is detached within the pile mass accidentally, then the excision of pile mass is to be done, because removing the glass tip is very difficult. This is how to clean the fiber and ETO sterilize before reuse. We are organizing the Ecosicon 2025 under banner of Association of Colon and Rectal Surgeons of India. This will be in 2025, and it is hosted by Ahmedabad surgeon team and Surat surgeon team, and all support from the whole Gujarat surgeons. Better safe than sorry. Thank you very much for patient listening. We welcome Dr. Kushal Mittal sir and Dr. Nitish Chawar sir. Sir, warm welcome and good morning, sir.
Thank you, Naresh bhai. We are taking few question answer after each lecture. So if any question, you can proceed from anyone. Because today is totally laser day, and we will sing in the sea of laser today. So you can ask any question anytime after each lecture. Before introduction of our speaker, I like to invite chairpersons, Dr. Ramesh Devani sir and Dr. Amulak Savani sir. Please come forward and chair the session. So, any questions, sir? Yes, sir.
Naresh, congratulations
Yes, sir.
for a nice presentation.
Thank you, sir.
ત્યાં જાણો સ્ટેજ પર આવી જાય વિડીયોમાં ત્યાં જઈને બોલો તો સ્ટેજ પર
No,
આવે
no,
ઓકે નહીં આવશે એટલે બેક સાઈડ આવશે
As you say, that the most painful area is anopictinous junction.
Yes, sir.
So whether to insert a fiber flow at anopictinous junction or little bit above or below, so that we can minimize the pain.
Some faculty are recommending at the dented line, but it is not feasible
It is too high. That I
It
agree.
is
It
too
is
high.
too high. Okay.
And if you insert from the outside, then it will be difficult to manipulate the fiber.
Okay, that
So
will be-
better is at anorectal junction. That is better.
આને રિમોટ કાં છે આપણું પ્રોજેક્ટર આગળ છે બહાર તો रिमोट से नहीं हो रहा है થઈ ગયું લાઈવ
हाँ, live तो start है।
सर रिमोट से हो जाएगा रिमोट रिमोट लो नीचे नीचे हाँ अच्छा रिमोट प्रोजेक्टर कनेक्ट कर प्रोजेक्टर कनेक्ट ऐसे नहीं होगा
Most of the time we have seen that it is the overuse of laser
Yes.
that induces the hazards other than the underuse of the lasers. So suppose by chance patient develops recurrence, better to apply for the second time
Yes.
rather than coming to the complication with overdose of the lasers. Because most of the time we have
Right,
seen.
sir. That is very true.
Yeah.
Yeah. So on table, don't wait for the total shrinkage of the bile mass, and stick to the basics and stick to the 150 to 200 joules. And if there is a recurrence, you can give sclero, or you can again use the laser in piles.
Very good demonstration of the laser in all the surgical procedures.
Thank you, sir.
Just a small question I would like to ask. While doing hemorrhoidectomy, most of the time we do the Doppler ligation of the hemorrhoidal vessel. What is your way of ligating? Whether you do palpate the vessel, then ligate it, or at times you go with the just anatomical position, because many times it may not be able to palpate the.
In case of enlarged piles, you can easily palpate with the index finger. If the piles is very small or a normal anodome, there the pulse is very feeble. So in that case, you may not be able to feel the pulsation. But whenever there is a proper piles, second, third degree piles, then definitely you can palpate with the index finger, just above the dentate line and just above the piles area.
What is the recurrence rate?
Of
Recurrence rate.
of which procedure, sir?
On laser.
Piles? Recurrence is slightly more than the Milligan-Morgan hemorrhoidectomy, because we are not removing any piles here. So it is 10 to 15% recurrence rate is there.
So-
But if the properly selected patient, proper indication, then recurrence rate is very less. So select the patient very wisely.
Thank you, Naresh.
Thank you.
We will take more questions because we have outside faculty here and they will give all answer. So please, we'll go for next session and introduction of our next speaker by Dr. Deepak.
Dr. Nitish Jawar, sir. Welcome, sir. Sir is a well-known faculty at Mumbai. Sir has done his MBBS from Gadvi Gandhi Medical College, Bhopal, Madhya Pradesh, and MS Surgery from Mahatma Gandhi Medical College. Sir is currently at Apollo Hospital, Belapur, Navi Mumbai, and Zen Multi Speciality Hospital, Chembur, Mumbai. Sir is EC member of West Zone of Accuracy 2023-25.
Will give you some insight in how we can use it more judiciously in your cases. As I was hearing the discussion, this discussion keeps on going because still we are lacking any standardization as so as to selection of cases, amount of energy which is to be given, and so many things which are still not clear in this field. So if you look at the laser and you compare it with the white light, how it is different. So if you look at the white light, it is the non-coherent, broad spectrum and non-collimated light. That means it will breaks in different colors and it will disperse as the distance from the source to the organ or whatever is the effective area is there is more, it will spread like a beam, it will not remain like a sharp focus. So how it is achieved? If you look at the mechanism, how the laser works, if you look here, this is the stimulation which is done by some source, and when this is stimulated, then the electrons, they move to a higher state. We call it a metastable state, from a ground state. When they are coming down, they will release something which is called as photon, and these photons will have a charge, and they are the ones who are ultimately going to form the laser. So initially when they are formed, they will keep on roaming in that medium, and once they go and hit the reflective surface, that is one mirror which is completely reflective, and other one is the partially reflective one. So when the beam comes out, it contains the same frequency, same phase of the photons, and that will have only one color or whatever the wavelength of that particular laser is. Now this particular thing is important because when you are choosing the laser machine, and Dr. Mittal sir will talk about it in his forthcoming lecture, you have to be very clear that when you know that the machine itself should have the capacity to generate photon, what are the various things you should look for. So this is the thing which is happening there. The photon is going up, and when it comes back, it is the one which is responsible for formation of laser. And when this beam keeps on hitting on these two surfaces, ultimately through a small hole in a partially reflective surface, it comes out, and that gives the benefit of laser to the tissue and finally to the surgeon. Now if you look at the wavelengths, there is a lot of discussion about wavelengths. We have to understand that right now in proctology, the wavelength which we are using is 1470, and that is a standard of care as of now. Things may change. The same thing we were talking about 980 a few years back, but right now the present recommendation is to use 1470. This is the difference between the two crest of the waves, which gives it a particular wavelength. And why we decide a particular wavelength depends on the concept of chromophore. Now these lasers, they are different from light, as we talked about. They have affinity for a particular tissue. In case of diode laser which we are using, they have affinity for hemoglobin and water, but there is a relative change in between the two wavelengths. If you are using 980, it has got more affinity for hemoglobin, but if you move towards 2000, then it has got more affinity for water. Now the advantage what you get is when you are using a higher wavelength, the lateral thermal damage to the tissue is less, and that is why you get more precision. So like you saw that video, was that clear? I don't know if it is right. No, it was not. Video is not running, right?
It was running, but you can't see it.
But you can't see it. Never mind, forget it. So what laser does to the tissue? So if you look here, it has got effects like hyperthermia, photocoagulation, photovaporization, and photoablation. Now this depends on the distance from the source of the laser to the tissue or the target organ. When it is very close, it will lead to something which is called as carbonization, which you achieve by using electrocautery also when there is complete charring of tissue. As you go a little away from that, there will be vaporization, coagulation, and then hypothermia. So as you move away, the effect of heat will definitely go down. When you're using something which has got more affinity for water, then definitely the lateral thermal damage is less. So you will not injure the tissue which you don't want to, and it will remain effective in the tissue which you want to have the therapeutic effect from. Now if you look, the beam will go through the tissue and it will meet three phases. Like it can go back, that is, it can get reflected. Some of it will go through the tissue and the remaining will get scattered in the tissue. Now whatever is passing through the tissue will have its therapeutic effect in the form of all these four things which we talked about. One more thing is the density of laser. So if you are using a beam and you remain at one particular point for a very long time, then it will have more heat generation, and that can lead to carbonization or burning of the tissue, and rather than a therapeutic effect, you will have a burning of the tissue, which is not desired in these cases. So you need to understand the density of laser also. That is why whenever we discuss about the use of laser in different conditions, we emphasize on total amount of energy which you are going to give, at what rate you are going to give, how fast you are going to move, and that is what is going to give you the actual effect. Now, you must have seen, Dr. Naresh also showed that once you heat the tissue, immediately you cool it down. There is something which is called as thermal relaxation time. When the tissue heats up, it takes some time for it to come down to 63% of the highest temperature which it has reached, and that is what is normal one for that particular tissue. So if you have used laser, we have never seen these things being done in pottery and other things, but since here we want to control the lateral thermal damage, we immediately cool down the tissue, which will increase the effectiveness of the laser in turn. So that should be done only for 20 to 30 seconds. Only up to the thermal threshold time, not beyond that. If you keep for 10 or 15 minutes, it is not going to add to the advantage. Now, if you look at the effect of laser which we talked about, the coagulation is between 50 to 100 degrees centigrade. As you go a little higher than that, then all of us know that more than 100 degrees the water evaporates, and that will lead to complete disappearance of the water from the tissue. And this particular quality of laser is used for giving clean cuts in the skin, and different kind of laser may not be diode, or if you are using a diode laser, we go for bare fiber. Same thing is with ablation, where it will break the chemical bonds and will cause a little bit of local heating, and ultimately will lead to a clean cut incision. And there is selective absorption. We talked about chromophores. Certain lasers, they will have affinity for different color and different tissue, and that is how you harvest the maximum advantage from this particular knowledge about the laser. Now the argument whether we should be using a 980, 1470 or 1940, which has come in recently, please understand, we don't want to damage the tissue, but we don't want to do away with the therapeutic effect of laser also. So if you are using a 980, the lateral thermal damage is more. Not that it is not effective, but it is giving you some undesirable effect to the tissue which is surrounding that particular thing. We really don't want it. If you move to a higher frequency, then probably your clinical efficacy of the laser may go down. That thing is still controversial. It has not been established so far. Whatever they have seen in cases of varicose veins, that though we are preventing the lateral thermal damage, but we are not getting the therapeutic benefits what we get with 1470, and that is established as far as endovenous laser treatment is concerned. But still, we have to find some guidelines to prove this, that the 1470 is the way, and it is going to last. Whether it will last the test of time, that time will tell. Now radial fiber, I saw Dr. Naresh showing you this particular thing, that if you look at the radial fiber, it is like a 360 degree, it is firing the energy all around. In the bargain, when you are having a beam which comes and hits a surface, and then you spread it laterally, the effect goes down by 15 to 20%. So this effectiveness of a radial fiber is around 80% of the normal setting which you have done, as compared to a bare fiber where the penetration is going to be 100%. Also, if you are in a cavity, please understand, when you are close to the surface, it will have more therapeutic effect vis-a-vis if you go far from the surface. So if you are working in an abscess cavity and you just put a laser fiber and expect it to collapse, it won't happen. Vis-a-vis if you are in a 5 or 7 mm tract, then definitely laser will have its maximum benefit to you. And if you are choosing fissulas according to that, then it is going to definitely help you. The difference between a radial fiber and bare fiber is what I talked about. The laser which is being emitted through a radial fiber will go 360 degree all around, but the bare fiber will have a straight penetrating kind of a beam which will have more of a cutting effect. If you look at the radial fiber, it will have more of a ablating effect, and the use of a radial fiber, the number of firings you can do using a laser fiber is limited, but in case of a bare fiber, it can last you a lifetime if you take care of it properly. Two modes which we use in laser, continuous and pulse mode. The continuous mode is mostly used in case of fistula, PNS and fissure. In fistula and pilonidal sinus, when you are using a continuous mode, we are using a radial fiber. Vis-a-vis if you do a fissure, we are using a bare fiber, because that is where we want to cut rather than ablate anything. And in case of hemorrhoids, we usually use a pulse mode, because otherwise you can fire the desired dose in a very short time without being able to move in different directions through the hemorrhoidal tissue. The lasers are classified by the medium in which they are produced. We use a diode laser. We need not go into the details of this, but only thing is we need to understand that you can't see laser with your bare eyes, and that is why it is mounted on a particular light. So if you look at the laser, 980 or 1470, this is infrared, you can't see. So it is mounted on a light so that when you point it to a particular organ, you will know that the laser is going to go and hit that tissue. Thank you so much. This is all about laser. Any questions, I'll be happy to answer.
The light. Any question for the laser? What type of laser fiber to use? Any question, please? Thank you, sir.
Sir, yes.
As far as the management of piles with laser is concerned, better to use a bare fiber or a conical fiber, especially using third degree or second degree piles.
Alright, so the bare fiber will mostly have a cutting energy, right? We are looking at shrinkage of the pile mass. So if you use any kind of a radial fiber, that is good. Now if you look at a blunt tip radial fiber or you look at conical fiber, both of them are radial fibers. So in the core, all fibers are bare fibers.
Yes.
So what we are, it is like a glass umbrella, which is dissipating the light laterally or laser laterally. So if you are using a blunt tip or a conical, that is the preferred way of treating in case of hemorrhoids rather than using a bare one. You can use bare tip fiber also, but then you have to be very cautious that you don't point it towards the mucosa. Otherwise, 3-4 days down the line, that thing will open up. You will have a submucosal abscess or a superficial fistula there.
But
so that has to be avoided.
What happens in a conical fiber? After 3 to 4 uses, usually glass is broken.
Yes.
And that induces a less effect on the tissues.
See, as it is, if you see, you are not supposed to use radial fiber for a very long time. And the second thing is handling of the fiber also. Mittal sir will talk about this. So that has to be fixed, that how many firing you are going to do with a particular fiber, and check, like Dr. Naresh showed, that the ring has to be complete and all that, and then only you do it. But if you're talking about cost saving, bare can be used, but then it will have a suboptimal therapeutic effect. The advantage is when you bring the fiber out, it won't bleed like what conical fiber bleeds.
As far as the pathology of piles is concerned,
Right.
even if you to what, like 980.
980. But there is no advantage as such.
So single wavelength.
Single wavelength is what you should be looking for. See why we have moved on from 1470.
And what about
Because the 980 was not giving us the desired results which we wanted, right? The damage was 4 to 6 mm in the surrounding tissue. So now we have moved to 1470, which has limited it to 2 mm. We don't need 980 anymore.
Sir,
Yes.
I am doing a varicose vein.
Haha.
So, action of laser in varicose vein and piles is different. Because in the varicose vein, there is an intimal damage.
Right.
Intima of the vessel is damaging.
Right.
And in case of the piles, we are applying a laser outside the vessel, probably.
Right.
Probably. So how will you see its pathological sir?
See, ultimately we are talking about a chromophore, right? When you are using 1470, it has got more affinity for water, right? Now, whether you talk about blood, you talk about the intimal layer, in hemorrhoidal tissue, when we are looking at CCR, that is the corpora cavernosa recti, it is impossible for you to go in each and every vessel, right? So what you are doing is a mass destruction. So when you do it, you don't want what we use as a laser-like focus. You want something which is diffuse. So that is why we go for a radial fiber. right? Now it has to be diffused so that it covers a larger area, but at the same time it should be safe. It should not go beyond that. So 1470 that way helps both ways. And here we are limiting the amount of energy also. You look at a bypass, you don't fire more than 150 to 200 joules. That is your maximum which you will go. If you are worried about more damage, you can even reduce the watt. Does that answer your question? No.
No, I am asking somewhat different.
Yeah.
In the vein,
yes.
Both are veins. Varicose
Right.
vein is also vein, this is also vein,
Right.
abnormal vein.
Right.
In case of varicose vein, we are damaging intima because we want collapse.
Yes. Right.
And here we are applying laser from outside.
From outside or inside, we will not know. You are going in that bunch of tissue and you are shrinking the whole mass. So you will take the vessel wall also. See, it will not. It is not only blood. No, it is.
This session is sponsored by Belgium Pharmaceuticals.
Okay. Keep the lights on the back. All right.
Okay.
Last row.
આગળની બંધ કરી દો, પાછળની રાખો. પાછળના બંધ.
Correct. Thank you, Dr. Naresh and Dr. Bhavin. You're doing really wonderful job in Surat. So many programs in the last 3 years. We're really thankful. Akarsi is very thankful that we have 2 people who are really active, and I am sure you have a lot of people with you, assisting you. They deserve, because if we calculate the number of people who are very, very active, so there are 3 people and they are heading on the top of the list. So first question I want to ask the audience, light nahi chalu kiya, so I can't get the answers. Light ka. The first question, how many people have laser machines? Okay. How many people want to buy laser machine? Okay, the other people don't want to do anything with laser.
Right.
The reason I'm asking is because then the lecture becomes pertinent. So, the people who have laser machines, how many have Biolytic? Okay, are you aware that Biolytic has come out with a new fiber?
Yes, sir.
You buy 1 cable and you get 2 extra fibers. That's beautiful.
One cable and 10 extra fibers.
No,
One
2 extra
central.
fibers. 2 extra fibers. Each fiber can be used for 5 times. They will tell you that's 10, but 2 fibers and they can be used for 5 times. The biggest drawback with Biolytic was the number of uses. And in India, we can't buy a fiber for every patient. So now that has come down. So they will be in the market for a front runner. How many have Lasertronic? 2. How many have Neo Laser? How many have Photonics? 1. How many have Lasermar? That is UU Photonics. EUPHO. Nobody. So, confusion when you want to buy the laser. I'm sure all of you have done market research and then you bought the laser machine. Yet there's no universal, everybody is not raising hand to one particular company. So that means they're going for different companies. So the things I want to tell you in this is, when you are buying a laser machine, what are the things you have to keep in mind? That's all. Which one you want to choose is your choice. You can't blame anybody. First, I want to make a disclosure. Okay. Can you give me your pointer? There. Okay. So, हो गया. This is yours. मेरा charge नहीं था. The disclosure I want to make. I'm using NeoV machine for the last 5 years. I've never had a breakdown and I'm very happy with it. But apart from that, all the machines I have talked about, I use it all across India for all the workshops. There we don't dictate which machine you want. Whatever a machine is sponsoring the program, that is the machine I'm going to be using. So in the last month, Jan 7, the program in Zen Hospital, we were using Merrill. Programs in South India, we use not photonics, laser mar. So it depends on where I'm doing it. So I've used all of them. And if you ask me, more or less, it's the same. But there are some hidden things which you don't know about. And those people who are going to buy laser, can you raise your hands again? Okay. Don't buy it till you have enough money. Okay? The reason being, we are trying to buy the cheaper one. We would like the company who gives the machine at a lower rate. But what you are losing in lower rate is what Dr. Nitish just told you. When you have two mirrors, you need that distance. So what they've done for India, this is for India. They started making mini machines, smaller machines. You can take it, put it in your pocket and take it to various places. But you lose out on the exact laser output. When you choose a laser machine, it comes with an energy of 10 watts. And you presume that the energy you're giving is 10 watts. But actually that could be only 4 watts or 3 watts. And you wonder why nothing is happening. So the reason is you have to be compliant. So two big bodies you have to take care of. One is USA, FDA USA and CE, that is for Europe. If these stickers are there on the machine, that means that machine will give you this, you will get 10 watts. You won't get less. That's why it's important to see those stickers. We don't see it, we just look at the price. And the next we look, what else are you giving? How many fibers are you giving? How many goggles are you giving? We're so concentrating on that. We don't understand that the machine you're buying may not be the machine other people are using. So when you're buying it, have at least 15 lakhs in your pocket, then go and look for it. Then do a market survey. Even I did it, even I presume Dr. Nitish did it. We saw all the machines and we started doing it. So why laser? Why do you want to do laser? Anyone? Why are we looking towards laser? So the first question you must answer is, why do you want a laser machine? Here. So we'll come to that in the next slide. Which wavelength should you buy? Everybody has told you 1470. Don't ask questions. 980 is terrible. I give an example. In 2014, I was giving a webinar from India to England and India to Japan. So they were at the interval of 5 hours because of the time shift. Many people asked me about laser and I was not doing laser at that time. So I asked two people who were doing lasers. One was Dr. Chute, sadly he passed away last year. And the other was Dr. Ashwin Purwal. I'm saying the names because they were the names in laser before our era. Our era has come down. Both said the same thing. It's terrible for hemorrhoids. So what was wrong? The machine was wrong. 1470 had not come at the time. It was 980. A lot of burns. They were not using a pedicle stitch. Therefore, a lot of bleeding. It was a messy affair. Using a laser was a messy affair in the bygone era. Which machine you should buy? I think by the end of the talk, you should be able to decide. How much money you're willing to invest? If you have less than 15, don't buy. Because you need to spend that amount. How much time does it take to recover 15 lakhs? Depends on your practice. A good practitioner can recover in 15 days. Okay? I took 2 months to recover it. It comes back. And then you start wondering, why did I talk about getting a cheaper machine when I get so much money from it? But if you have bad results with a bad machine, then your practice is going to go down, not up. So you have to be careful. Can your setup afford laser fibers if charity or government? Now this is a big problem which has occurred in Bombay. Two big hospitals, one is Nair Hospital, the other is Sion Hospital. They both were given gifts, laser machine, and we told them, don't buy that machine, fiber, you'll get stuck with the fibers. They bought the machine. The machine is lying in the operation theatre. They're not using it because the government is now sanctioning the fibers. So they're stuck with the machine. So if you want to buy it, make sure the charity hospital or the government can actually pay you for the fibers. What training course have you taken? Now, unless you have bought, if you haven't bought a machine yet, first go for training. See what it is like. Feel what it is like. Feel how when you pull the fiber, what tug you get. What is the right way to do it. What is the amount of energy you have to give it. Learn all that. Don't jump in to buy a laser machine first. First, be confident. Yes, I think I can do it. Then you think about buying a machine. So, inside any animal tissue and withdrawing it and see the tug, how it feels. So you get a confidence, okay, something is happening. How information, the spelling is wrong. What information you need to know is what I'm going to tell you. So why do you want a laser machine? Anyone, why do you want to buy a laser machine? The guys who said I want to buy. You have to answer. This is, it'll become interesting. Why do you want to buy? Patient demand. That's true. That's number one. If patient did not demand it, we wouldn't have bought it. Because surgeons are very reluctant to change. They're already doing good hemorrhoidectomies. They're already doing good staplers. But the patient comes and says, no, Baba, I want laser. So he can go and tell his neighbor, I got it done by laser. You do it well, then neighbor also comes to you. You do it bad, the whole city doesn't come to you. So you have to be careful. What else? Patient demand is one. What else? There are some things in your mind you don't want to say it because in front of people it would sound bad. But let's see. Fame. He does by laser. Money. Definitely yes. The laser patients I do pay 2 to 3 times or more than the routine patients. And they do it happily. You do a hemorrhoidectomy, 20,000 they will be crying to give you. You do a laser hemorrhoidoplasty, they'll pay you 60, 70,000. We know hemorrhoidectomy is a better procedure than the laser. But you have to put everything together. Creating demonstrator. That in one road you have 10 surgeons and nobody has a laser, so the guy who buys first, that's where all the traffic will go, right? All the people know, okay, don't put it. The fifth one, he has laser, you go to him. So that is a differentiator. You are standing apart from other people. Demand by the patient, I put it low down. Results are better. It is in the terms of time taken to do it. If you do laser hemorrhoid and do it properly for all the 3 hemorrhoids, you should not take more than 15 minutes. In fact, in Chennai, year before last, I was demonstrating laser in hemorrhoids. And I finished the whole procedure and just asked me, sir, when will you start? Now, she didn't understand that I've taken the stitches, that I've already fired the laser and she's waiting for the Patani laser mein kya hone wala hai, what big stuff is going to happen. And she was waiting for the program to start. Let's see what laser is like. When I told her it's finished and she was so, upset. 15 minutes. It was less than 15 minutes. So results are better only if you do it better. If you don't do it better, the results are so bad that patients die. And I will show you those photographs. And it's only because you did not adhere to the line. So how many people have lasers? Again. Now if I tell you that you have lasers, I will show you a few videos. You go and do laser liposuction or you go and do laser vaginal tightening and you start doing it without knowing the nuisances of it. Just because you're good in laser proctology does not mean you will be good in that and you are going to ruin the patient. So you should know each procedure you're going to take the laser onto. So this one, there is no question. We already discussed. which machine should you buy? Now that's a very tricky question. Obviously, I would say NeoV, I'm using it, I have no problem. Nitish will say Lasertronic because he's using it, he has no problem. So if you're using it, you have no problem, it's fine. So when you buy and your friends have a laser machine, you ask them, you bought this machine, do you have any problem with it? What are the problems? When you find burning the way it should, or it's over burning, or the machine conks off, or the machine sound is not there. Something going wrong with the machine. So you need to know, ask your friends, ask your teachers, and ask us, we'll tell you. What are the things we keep in mind? First is the cost, then the fiber. Many machines are selling at a lower price and they give you just one bare fiber. They don't give you conical, they don't give you radial, they say no, with low cost. So the money they save around 70,000, they take it off from your bill and you're happy I'm getting a very cheap machine. So that's what I said, when you want to buy, spend money. Goggles. So how many goggles are they giving you? They generally give you 2. You have to negotiate for 3 or 4. They will give it to you. You have to put your foot down. I don't want 2, I want more than that. And then after that buy 2 more from them. Should have at least 5 goggles in the OT. Hand instruments. Achha, let me ask you one question. Do you think the anesthetist has any problem not wearing a goggle? Yes or no? Those who are using laser, do you think the anesthetist will have a problem when you're using laser?
Yes, sir. Reflection.
Correct. The laser goes in a straight line. Any reflective surface in the OT, that means your TV monitor, the plastic covering you got on that, any steel surfaces, the laser will go there and bounce back, and where it goes in the OT you don't know. So you have to make sure people in the OT are covered with laser. And if they don't want to put the laser thing on, goggles, they should look away. They shouldn't look anywhere near towards the operation theater. Then hand instruments. Hand instruments are very important, especially when you're dealing with hemorrhoids and when you're dealing with fissure. You don't have a hand instrument, it's really difficult to do it. You can do it, but it's difficult to do it. So ask them which hand instruments they're doing. Generally they give you 3 hand instruments. I've seen the one Biolytic is giving now. They've got a small box like wooden box and they've got 5 hand instruments, which is very neat. Training. Most laser companies will provide the training when you buy it. When you don't buy the machine, they will take the money from you for the training. And when you buy the machine or you can pay for the training, they will give you that much discount on the machine. Take that because the training is really important. Troubleshooting. So, are they able to help you? Suppose, I'll give you a small example like somebody already talked about the cap coming off when you're doing a laser hemorrhoidoplasty and it is inside the hemorrhoid. Now, if you phone up and say my cap is lost in the hemorrhoid, one company, I know this for a fact, they said we can't do anything, we don't know what to do. And they phoned the other company said do a hemorrhoidectomy. Or you can say explore and take it out. Or you can say just leave it alone. But they should know. What happens is these people who come from, I'll give you an example, mirror machine I worked on, the people who were setting it up didn't know anything about the laser. So you need a person behind the machine who knows everything about the machine. He should train you and your staff. So when my new V person comes, I take a training of the staff all over again. Every time he comes, I do the training. Because it is the staff who keep changing. They may not be the same people. Warranty. Now most companies don't say we have a warranty. They'll say, you know, my machine doesn't get bad and we will give you sales service. But have a written warranty. Some machines are giving a 2 years warranty, ask for a 3 years warranty. The problem is the machine for 5 years nothing happens to it. So warranty, after when it happens your warranty has gone. But the smaller machines, the machines where you pay less amount of money, that you pay and get the warranty, because those machines are conking off. Those machines are stopped working. When you're doing it, it just doesn't work after maybe 6 months or so. There you need a warranty. The smaller machine you have, the bigger warranty you want. After sales service, do they provide it? You have spent so much money and you're calling them, will come tomorrow, will come day after. They take 3-4 days to come, and you have lost all those patients in those 3-4 days. So you need somebody who is prompt, who can come, who's near you, who has a center. Suppose Surat is there, center within 200 kilometers of this place, so that person can come. And if they come, they should be so big a company that they can give you a replacement piece. Talks of use this, we'll go and repair it. But you know that most laser machines can be repaired on site. It has to be by a good technical person. Backup machine, they should have the power to deliver it. Now, Photonics, I talked to them day before yesterday. This is their claim, that if something goes wrong with your machine, they don't do sales service, they will replace the machine. How far it is true, I don't know. Nobody in this hall has Photonics, so I don't know. Portability. Some machines of the yester era were so big, you could not take it from one place to another place. Nowadays, the laser machine comes in a very nice handbag and you can take it away. Those who have lasers, again, raise of hands. Are you operating in one hospital or different hospitals?
One.
How many people one hospital? How many people different hospitals? So that means you're taking the machine from one hospital to another hospital. Okay. Now I presume Surat has very high temperatures during summer, around 40-45 degrees. If you keep that laser machine in the dicky of your car, the machine will get bad. You have to keep it inside. Where you are cold, the AC is there. If you're going on a road which is really bumpy and the machine is also going over the bumps, you are going to, that life and the wear and tear will make the machine bad. Those people who have the machine at one place, their machine lasts a longer time, has less problems. You know, all the components are there, thousands of components, and you're taking it through a really bad road, and a very hot day, your machine is going to become bad. We should know that when we are doing portability from one hospital to another hospital. So, now all these prices are the prices they want, and you can talk and negotiate with them. Okay, they will all come down by 1 or 2 lakhs. So, this is Neo Laser 15. The range goes from 12 to 15. That depends on the things they're giving you. How many fibers they're giving, how many goggles they're giving, how many warranty they're giving, are they providing training. After all, they're not going to pay for training. It will come to your machine cost. Take the training. Always take the training. Then you have Lasertronic, is 11 plus 11 lakhs or more.
Sir, last one, please.
These minutes nahi hai, it's all one.
Okay.
Minutes only for narration, Bhavin, baki hum log ke liye minutes.
Okay, sir.
Then you have Biolytic, and everybody is fascinated by this 7 lakh machine. You can get it for a little less also. But the problem with the 7 lakh machine is, I'm going to get one machine today in Surat, simply to give a trial on it, how it is. It was in a buyback. So they bought the machine back, only 6 months old for 50,000. So I'm getting that machine to see what was going wrong. Then you have the bigger one. If you want to buy Biolytic, please buy the bigger one. They are good. They are really good. Then you have Photonics. I'm going to come on this on the next page. Then this is the Photonics. They say 10.5 plus GST. Now, if you go by rate wise, they have the best rate. If you go by service wise, they replace the machine. If you go by warranty, they have the warranty. If you go by FDA, that is USA FDA, then you have Neo Laser and photonics. Not this one, U-photon. This one doesn't have US FDA, even though they say they have a plant in USA, which is surprising because if you have a plant in USA, you should have US FDA. So those things we never look at. Being Indians, we just want price. Which machine has a lower price? Don't go for a lower price machine. Their rates are good. The probes they provide are good. The goggles they give you is good. Service I've already told you. But up to now, they say they claim they have sold over 1,000 machines in the last 1 year. But of all the people I have talked to, nobody has one. So I'm wondering maybe they're selling to ENT or some other faculty. Surgeons don't have it. Then you have this laser mark, U-photon. These are a hit in South India, and they're buying in bulk. Abhi, Nitish, Apollo ne U-photon liya. Yes. So Apollo bought U-photon, so they're buying means they bought 50 machines. So obviously they must have done research, and the smaller one, mini one, is for 11.2, and the larger one is for 17.3. You have to understand a big tax chunk is also there. And they're giving you the required fibers, these three, handpiece 1, interlock safety connector 1, cable 1, foot switch 1, eye protection goggles 2, and adhesive label, you know. Now, see, this is what I'm telling you. Read this. What is it? It is a small sticker which says, attention, laser is working, which you can make for 10 rupees. So why do you have to put it in a list like this? Because the person who's buying says, oh my God, he's giving so many things. So you got to really research. And please remember, these figures have not come very easily. I had to call each company up and ask them the price and told them how important it was for me to talk about the price. But they say, I've used it. The first time I used it in Jen Hospital, Coimbatore, the machine was working, but the laser light, the red light was very dim, and there was no sound. So now imagine you are using cautery and there is no sound. So you don't know whether the cautery is on or off. So I had the whole OT keep quiet. Everyone was talking, keep quiet. There was a small sound. Please, even the highest volume. There was some problem in that machine because I did it again in another hospital. It was working well. Then Merrill has come out with this 6.5 lakhs plus GST, which I believe all surgeons will want to jump to it. कि अरे the price तो बहुत अच्छा है and it's portable. But you have to actually go through the details with other machines and find out whether this is really suitable for you or not. Price wise is good, it is small in size, it is portable, but it's got its own deficiencies which a larger machine doesn't have. So laser company training, if you bought the laser machine, they have to come to your place and they have to tell you how to take care of the machine. One of the things I will tell you how to take care of it, if your machine is lying in the open and you fumigate the OT, what is going to happen? That fumigation goes through the vents, so you have to cover it or keep it in the bag. You can't leave it open and do a fumigation. What are the OT safeguards? That means removing all the problems in the OT, surrounding OT. Machine should always be in standby mode. That's what they have to really tell you. Foot switch has to be locked. There are many companies who supply a foot switch, but there is no lock on it. That means the laser is in your hand and your nurse accidentally presses on that lever and it gets activated. You don't have your goggles on and you were not planning to do it. I mean, in that particular time, and the machine is on because there is no safety. So some of the companies which did have it, they started doing it, but there's still some companies which don't have a foot switch lock. That means there's a cover on the foot switch. Until you open that cover with your foot, you can't get access to it. goggles for everyone in the OT, where we have a training institute at one of the training institutes in Punjab. We have 25 goggles. So those goggles have to be taken. They are not cheap. The cheapest one is 12,500 and the best one is 25,000. So you have to think. Proper settings, how to set. Setting, once you do it, it gets fixed. But you have to know how to do it. You can't get the laser guy to come and tell you how to do it. What am I talking about? Suppose you're doing a fistula, you want 10 watts per millimeter per second. Maybe you're doing something else, you want 8 watts. You should know how you can do 8 watts. You're doing a hemorrhoid, you want pulse mode. You want to know how to do a pulse mode. You have to practice all this. Don't leave it to the OT technician, because that technician may change and you haven't learned it, you're stuck in the OT. Font size on machine. I'm going to show you this. If the fonts are small, you don't know how much energy you're using and you don't know what is the total energy because the fonts are small. An example, Lasertronic has big fonts, NeoLaser has big fonts, Beryl has very small fonts. I can't see it. So if you can't see it, you have to tell your OT sister, keep saying how much energy joules have been given. Aiming beam. Now, Nitish has talked about the aiming beam. Aiming beam is 351 nanometers, and the color you see is the aiming beam. That is not the laser. Laser, it is colorless. So that aiming beam comes. So take a strong aiming beam, the highest 100, and when you do it, it's like a small focus of light. You can see the tissue also in that light. Proper sound. You would be surprised to see, whenever you see a lot of demonstration in the conferences, press the foot pedal and hear the sound. If the sound is not good enough, forget it. Don't buy that machine. No reflective surface, I've already told you. Fiber care, Naresh has already talked about it. We'll show it to you. And storage, how to do it. Outside the OT, there should be a warning light. There should be a red bulb. When you start laser, that red bulb has to be on, so people don't keep barging in the OT because you're using lasers. You don't want to do circular. You have to learn the controls and the connections. I am very sure that 50% of the people who have laser in this room, if I were to tell you your OT technician is not coming, you can't put the laser machine on. It's not switching on. There are many things involved. You have a small little stick which has to go in the back. Unless that goes in the back, the machine is not going to turn out. If your emergency button is out, the machine is not going to turn on. So you have to know all those things. Laser outlet, where it's coming out from, it has a notch. All machines have a notch. You have to match the notch. What people are doing, they try to push it in and you break it in the fiber, you lost that fiber. Or you break it inside the machine, then you have to change that. So see the notch, match the notch and then turn it. Standby button, I've already told you, power connection, foot switch port, door interlock. Door interlock is something which is available abroad. When the laser machine is on, the OT door is sealed. There's automatic lock. The moment we press the pedal, the OT door gets sealed. Service port and connecting fibers. So this one has already been said. There's so much confusion. Are pulse mode kisme dete ho? Only hemorrhoids. Everything else is continuous. There's no confusion. So it has to be cost effective for all anorectal surgery. It has a preset. So in my machine, pylonidal sinus 10 watts, fistula 10 watts, fissure 10 watts. Hemorrhoids 6 watts or 7 watts or 8 watts, whatever I want, for 3-second pulse. That is fixed. You don't have to do anything. So most machines, coming to which machine to buy, in the higher bracket range are very good. Machines costing less may have hidden charges or default on add-ons. Like they may not give you fiber, they may not give you goggles, they may not give you hand instruments, they may not do training programs, and you are very happy because you got the machine for cheaper price. You have to think and consider cost of the machine, the number of fibers they give you, minimum 3 they should give you, 1 of each type. Number of goggles, at least 3. Hand instruments, all the hand instruments they have, you have to have. Location of the service center, find out. You're buying in Surat, where is the service center? Warranty for at least 2 years, try for 3. And USA FDA and CA approval is a standardization. Please check it. Ask your friends who are blazer, they will guide you. Now, any questions after this? Lights. Believe me, this matter is not in the book. You have to sit down and think all the questions people are asking and according to it, make it. In fact, in the train, I asked Nitish, do you want to add something? So he added a few points here and there.
Thank you very much, Dr. Mittal, for such a nice lecture. Now, any questions from the audience?
Sir, next lecture. So we are taking questions afterwards.
Okay.
Next chairperson is Dr. Naresh Arora and Dr. Bharat Sonani. Sir, next lecture is yours, sir.
Mine?
Yes, sir.
अच्छा कौन सा है?
Laser hematoblastoma.
What may have seemed to you a very lengthy lecture, but it was an important lecture because this is the first thing anybody asked me, how to decide how to buy which machine. Okay, you can turn the lights off. Last row chalu rakho. So we're going to talk about laser hemorrhoids. Laser hemorrhoids is not a difficult procedure, but it can become a very difficult procedure and it can cause a lot of problems. It's laser hematoplasty. All we have to do is insert the conical fiber into the mucocutaneous junction, go to the hemorrhoids and burn them out. It is a two-step procedure. The first step is you have to palpate the humeral artery. The reason you can palpate is when the anal cushions become hemorrhoids larger, the volume increases threefold. Therefore, before you can palpate, now you can palpate. 3, 7, 11 are the standard positions. You can palpate or you can just tie them off there. And the other places you palpate, and if you feel the pulsation there, you need to take a pedicle stitch. So how do we take a pedicle stitch? We go in, the thread comes there, lift it, and the next bite is a little deeper. And that's how you do the finger guided humeral artery ligation. Step 2 is to address the hematological mass by doing a laser hematoplasty. You enter with the laser fiber at the mucocutaneous junction, go up to the pedicle, and on your way out, you are going to do the laser ablation. So, what this shows is superior electoral artery is there, and you're doing FG Hals, you're tying this. That's the attempt. And at the mucocutaneous junction, that is where the intersphincteric groove is, that is where you enter with the fiber, go up here to the humeral tissue where you have tied, and you start burning there. So this is the entry. First take a pedicle stitch, then, and on your way to burn it. The entry is 6 watts for 1 second, and further on when you want to manage the hemorrhoid, 6 watts for 3 seconds. So, pre and post laser, that's the hemorrhoid mass, and this is how it becomes fibrosed. So, choices to make. If the hemorrhoids are very large and edematous, it would be wise to give injection Hylase 1500 international units diluted with 1 cc of distilled water per hemorrhoid, and that will decrease the size of the hemorrhoid, so you have less tissue to burn. And otherwise, that edematous tissue, if you start burning, then you will use a lot of energy and post-op complications will be there. The immediate shrinkage, this is Hylase being given, and see the shrinkage. Now it's easier to manage. Now, where is the mucocutaneous junction? The LS is at the inner verge, and this is where you see it, and the dentate line is higher up, and you see the hypertrophic papilla there. Right? So this portion is the enoderm, and you have the mucocutaneous junction. The patient should be positioned, and his stirrups have to be good. This is like yellow pins. It's available for 1.5 lakhs. It gives you a very nice position and very nice field to do the surgery. Tips before using laser. It has to be used after hands-on training. Don't do it otherwise. What is happening is people are going online and they're looking at the videos available online. I have seen those videos, and to my shock, at one of the phases of the video, when it goes up, you see the amount of energy delivered. 1200 watts. If you have delivered 1200 watts to the patient, what is going to happen? So energy pulse is 6 watts, pulse duration is 3 seconds, total energy is 150 joules, so it should be not more than 200, 150 is ideal. And if you are doing the right way, you will not require more than 120 to 150. Tiny carbon particles will stick and they will increase the temperature, so you have to remove it after every hemorrhoid. Laser light should be used with pinpoint accuracy. Fiber may stick to hemorrhoidal tissue, so when you are doing it, you have to keep rolling it, like pin roll movement. So the fiber doesn't stick to the tissue. What happens? You fire, it sticks. And you pull it out, you have torrential bleeding coming along. So if you keep rotating it, it doesn't stick. So it's a conical fiber and it's got a handle. So that's the fiber you get. You can have a handle like this or a handle like this. And what people want to do is, they want to perform the same surgery, taking a shortcut and using bare fiber. I have tried in 2 patients with bare fiber. I have had a lot of problems. Even though the energy delivered was perfect, the procedure was done very well. Patients, one had a lot of pain and the other had bleeding. I would not ever put a bare fiber inside. Use a conical fiber. Don't take a shortcut. You're taking a shortcut with the patient's life. I will show you the pictures later on, and after seeing them, you will understand what I'm trying to say. That comes in the second last lecture of mine. You don't need many instruments. All you need is sim speculum. You need the fiber, of course, and anoscope. Everything else you can do away with. Needle holder, obviously, you need a long needle holder. You need the goggles. This is at the entry point for 1 second. We have stopped doing 1 second. We know how much 1 second is. So just press on the pedal and let go. That will make the fiber go inside. Then further on, 6 watts for 3 seconds. And the suture you have to use, you can use a normal 2-0 vicryl. But if you want to do a lot of piles and you want to do it in a good way, the needle should be 27 mm, 5/8 of a circle, vicryl 2-0. And the length is usually 100 to 120 centimeters. So you can tie all the knots just with one suture. So what do? We pull it out, we see the mucocutaneous junction and palpate above and take a stitch and do a femoral artery ligation. After you've taken the stitches to all the places, you've done 360 degree, then you come for ablation. So entry from mucocutaneous junction, activate the submucosal space of the cushion, withdraw the fiber 5 millimeters, and activation is fiber in fan shaped manner, which I will show you. And after that you can cool it. Cooling is of many ways. One is the way Naresh said, you put a finger glove there with ice. The other way is take a gauge piece and put it, when you start the surgery, take some ice, put it in the kidney tray, put gauge pieces there, take a gauge piece out and put it there. The third, which I use more often, is in that kidney tray, I just take 10 cc of saline, that cold saline, and after doing it, I will flush it at the same time when I'm doing it. So the total energy activation, 6 into 3, 18 watts. If you have 6 to 9 activations, 108 to 162. So how can you reach 1200 is beyond my imagination, and that's where the whole problem occurs. So we have told you about this. The tip of the laser is sharp, conical, in pulse mode, and to withdraw 5 mm. Now look at this picture here. This is how you do it. First you tie there, you tie the laser, then you enter with the laser fiber. You give this punch, come out 5 mm, go one side, go the other side, then withdraw 5 mm, go one side, other side, keep going down, and you will do it. You actually never require more than 2 rows. These 2 are sufficient. Let's see. Palpating, taking a 2-0 Weichel stitch. And before you tie it, your assistant should press on the hemorrhoid to milk it so that blood is less, and then you start doing it. This was for grade 2. That is showing you should not be too superficial, you will burn the mucosa. If you are too deep, you will burn the internal anal sphincter. Grade 3. Palpate. Take a stitch. And there should be spinal leveling. The more you do, the better you get, and the results are better. Initially you are over enthusiastic and you give too much energy, which later on you understand giving less energy is beneficial. I think I have exceeded 150 watts maybe 1 or 2 times, otherwise I generally remain below that. Your stitch has to be good. So once you have tied it and you have given laser, it works. So do it all around. 3, 7, 11 are constant, and the other ones you palpate and you introduce a laser fiber. Now the laser handle has become better, and that shows you it's longer. Some people are doing it without the handle, and just because they were doing it without handle, I said let me try a few cases. It's difficult to rotate and it's difficult to angle. If you have a solid handle, it's easier to do it. So reduce everything, and when you pull the gauge piece out, this is called Park's test. It evaluates the size and the extent of hemorrhoids you have to do. Now when you keep seeing these videos, they say it looks the same. That's how it should be. All surgery has to be standardized. Now you've taken the stitch. So I'm thankful to Dr. Kamal. We form a good team across India. We go and operate together, and some of these videos are his videos. That's milking the hemorrhoids. And then you palpate again. Can you feel it? If you feel it, you have to take another stitch. You need to understand it is a very important part of the surgery. Some people are doing hemorrhoids without taking the stitch. They are getting away with it, that's good, but it can cause a lot of problems. So if you break down each surgery into steps, you will find that it's become easier. And when you are firing, you can hear the crackling. That means your fiber is good and you are in the right plane. Patient is training, there is no prolapse. This I will come later, but I tell you, this patient hemorrhoid surgery was done and this whole thing burnt out, this whole tissue, and he became incontinent. So take home message, case selection is mandatory, should be grade 2 and 3. Don't chase the hemorrhoid size. Please try to understand these hemorrhoids will shrink only after 3 weeks. Your job is to give the energy and let it go. You give energy to make it shrink on the table, you will give up to 1000 watts. Don't burn the mucosa. If you think it's getting burned, take it out. Don't enter through the sphincters. Some people are entering from outside. Use ice immunity to remove the latent heat or ice cold water. Total joules, if you're above 250, you're definitely going to have a complication. Any questions?
Thank you so much, sir. Very basic theory to practical.
Any question from audience regarding purchase of machine and procedure for laser hemorrhoidoplasty? Sir is eminent in this surgery, so you can ask the question. Anyone, please?
Sir, one practical question to you, sir. Hello, sir. Nice presentation of theory as well as practical approach. One practical question to you, sir. How do you deal with the external component?
You have to excise it. If you're doing stapler, you have an external component, you have to excise it. If you're doing laser, you have to excise it because the external component will become very big after laser. So excise it on the table.
So, sir, one more question.
Yes.
What do you explain pre-operatively if they insist to ask you a practical question? Will you do it with the laser or not? What do you explain to the patient and relatives pre-operatively?
For piles or for anything?
For piles, external piles. For external piles. I mean, I can
Okay, for external piles, I will tell them this has to be taken out. They say no, let them go. In Mumbai, I don't think anybody will do it because they will all say it has to be taken out. Don't fall prey to patients. They will try to blackmail you. You said you will do it with laser and you have not done it with laser. No. For fistulas, when they come to me, laser se karna hai. I said that decision is mine, not yours. I can tell you I have a laser machine. I have a waft machine. I have everything you need for fistula. But the decision to do what? It rests with me in the OT. We are fearful. Why do you give in to the patient? Don't give in. You do the right thing. You don't want a recurrence and you don't want incontinence. Whatever it takes, prevent those two things and don't listen to the patient. Well, I will use laser. Use laser. But use laser like a cautery. Patient is happy, you are happy. You are not compromising on the procedure. I'll come to that procedure. Yes.
So what is your approach when patient comes with a thrombus prolapse piles? How you manage?
Thrombus, internal or external?
Internal, external.
Okay, internal, external, thrombus, prolapse, piles, laser has no business. If you want to do with laser, the procedure to be done is hemorrhoidectomy. You can do it with laser. जैसे कॉटरी यूज करते हो वैसे आप लेजर यूज करो बट डोंट देयर इज नो क्वेश्चन एवरीथिंग इज थ्रोम्बोस्ड आप अंदर डालोगे किधर
Sir, if you are doing both laser as well as MIPS,
I don't do MIPS.
You are not.
I stopped. I do chotis.
Okay, so if a patient comes for grade 2 piles and if we ask for MIPS as well as laser and chief test with laser, what will you suggest, sir?
I will do chew test with laser, there is no problem. See, but once I finish chew test procedure, if there is any remnant hemorrhoid, I will fire. If there is no remnant hemorrhoid after I finish that procedure, I will not do. You see chew test procedure, how big hemorrhoids become very small. If they become small, I am not going to do anything. I need the hemorrhoid tissue to be there.
And in chief test you are doing 2 layer or?
2 layers.
2 layers. Standard 2
Standard chew test procedure is 2 layer.
Yeah.
We are taking a shortcut of doing 1 layer, compromising on FG Hall. FG Hall है तो एक layer कर दिया. And sir was very upset. You know, he said, I don't know. I taught them 2 layers. People are doing 1 layer and then firing laser under it. 2 layers is good.
So 2 layer, take home message is 2 layer and laser.
Laser if you need it.
Yes, sir.
Laser is not compulsory. As you know, in chew test procedure.
And amount of laser like 150 joules you suggested. If you are doing.
If I have small hemorrhoids, they won't even go 100.
Okay. So upper limit is 150, lower you can.
Lower it can be anything.
Many times we can see the secondary piles along with the 3 primary sites. So should we enhance this laser anode?
Yes, you can do it. You can do it. But if you have tied the suture at 3, 7 and 11 and there are no hemorrhoids, like 3 and 11 hemorrhoids are there, 7 when there is no hemorrhoid. Laser has no business in going inside. Leave it alone. You have a secondary hemorrhoid at like 5 o'clock or 2 o'clock, do that. But if 3, 7, 11, there's only 1 hemorrhoid and you've tied the 3 places, you do it at only 1 hemorrhoid. Whatever needs you do, extra नहीं करने की जरूरत है. It's you're playing with the devil and you need to know how to control it.
So what is the recurrence rate?
Pardon?
Recurrence rate.
I don't know. झूठ बोलूँगा, सच बोलूँगा. I don't have any recurrence, so I don't know what to say.
Okay.
Okay, maybe I have not done enough thousands में, but all the ones I have done, I have had problems. Like one patient जो bare fiber किया था, he had bleeding, and one patient had pain, but recurrence में नहीं.
Sir, what will you do if the puncture mucosa by the laser fiber?
Okay, don't worry. Don't worry, pray. Okay? Take that fiber out. We discussed this on the train, because we were discussing, you know, some things you discuss when you're traveling together or when you're having drinks. So this was one of them. He said his problems, I said my problems. So one of the problems which came up was, if you puncture, don't worry. Withdraw and do it like you did normally. That's all. Don't fire there. बाहर निकल के आओ and go in and there.
The role of antibiotic?
देखो, antibiotic, as you know, we are all students of Parvesh, and he doesn't use antibiotics. And I always said, you know, बड़ा आदमी है, no antibiotics. Then finally, you know, after hearing so many times, I started giving 1 pre-op dose and 1 post-op. No problem. You know, we consider our country to be very dirty and we keep giving over and over again. You say, you know, motion ka rasta hai, patient needs an antibiotic. Patient doesn't need an antibiotic unless the patient has other problems. Patient is diabetic, patient is immunocompromised, patient has a cardiac valve, cardiac condition. Yes, but routine people, you'll be surprised, you know, my RMO says, sir, antibiotic band kar diya. Why do you need antibiotics? So you see, if you really need it, you give it.
We also do the same. First dose pre.
I know, the rest said that.
Sir, we had 4 cases post-operative bleeding in a chip test procedure. We have done more than 150 around cases till now, and 2 cases where we had to operate. And in one case, there was a bleeding ulcer like that, and it was managed by the suturing 2 patients. And one patient has something fish aneurysm type in a multiple time operated patient. We have operated 2-3 times. We have operated 1 time. Another surgeon, my friend, has operated another time. And last patient has to undergo the CT angio. And we found some heavy aneurysm type lesion.
So what's your question?
So sir, what's your experience in chip test procedure post-operative bleeding?
Okay. I have two patients who had post-op bleeding. One required transfusion and the other one didn't. And I really sat down and said, what went wrong? All of my, everything I do is recorded. So I went back to the videos. So when you are tying the shoelace, you've taken the double loop and you're pressing down. Sometimes, maybe you're thinking about something else, maybe you're worried it will become loose, you tighten it too much.
Too much.
Okay, now post-op, you have edema, and that edema cuts through, and then you have bleeding. So that was the bleeding. So one had to get a sclerotherapy done by a gastroenterologist, and the other one settled. But that was the reason. Too much over-enthusiasm.
Maybe.
Those people who start new, they're the ones who get stuck. Tight karenge. And tight means post-op that is going to cause, edema is going to cut through. Any questions in the back? Sab piche kuch puch. Yes.
Any specific medications like calcium doxylate or
देखो हम लोग ना we are fans of flavonoids, so we don't give calcium doxylate. You ask him, you ask anybody, we don't give calcium doxylate. We give flavonoids, MPFF. So they work really nice. We give it for all patients who are undergoing anal surgeries because it improves the lymphatic drainage. It increases the venous resistance. So that means the veins don't pool, the veins don't dilate, it decreases it. And thereby the healing is faster. Yes, we start for 3 tablets for 4 days, 2 tablets for 2 days, 1 tablet for 30 days, 1 gram each. Any company you want.
So
Yeah.
sometimes after completion of Chute procedure, when we palpate the suture line, many times we found it a little loose at some
Yeah,
point.
it's okay. Because that loose, next day palpate, it will be tight. That's okay. That's, that is the reason why people do it really tight. So don't do it. Or if you on the table you feel is very loose, you go back 1 step and take it again.
So in a patient having very engorged anal verge, in spite of having secondary or 13 price, do you use laser while manipulating all this engorgement at the anal verge?
You mean to say circumferential? I think shortest procedure and stapler would be the best. You can do it with laser, but you will be in a problem.
Because I have experienced at least 15 to 20 cases by using at a lower range, 6 watt only.
Okay, he's saying he does circumferential hemorrhoids by using 6 watts, and within you have to do many
15 to 20 zools only.
Okay, so
it gives good results.
For circumferential hemorrhoids, the best is Chutes or stapler.
And
it takes care of the
point, your question. Hemorrhage or ulceration after Chutes procedure. I had 3 or 4 occasions where I used sclerotherapy while preventing the hemorrhage in that particular, because it is not possible to take stitches over there.
Because if you want to take stitches,
post-op,
if you want to take stitches, you have to be at least 1.5 centimeter above.
That is
Otherwise, it will cut through. Any stitch you take will cut through, and you have to be wider. And sclero is good.
Okay, sir. थोड़ा volume बता.
नमस्कार.
Yes.
How to choose between laser and stapler?
If you are comfortable with stapler, you do stapler. You are comfortable with stapler and the patient demands laser, then you have to think, should I do laser or stapler?
Okay.
The indication for lasers is grade 2 and grade 3 and not circumferential. So if it's grade 3 and circumferential, it goes to a stapler. So when you are buying a laser machine, do it for the lower grades. Don't do it for grade 1. Some people are doing for grade 2. It should collapse at least, and it goes back on its own. So it's a very difficult question to answer because they are absolutely different things. Apple and oranges हो गया.
Exactly.
So can you repeat the dosage of flavonoids?
Flavonoids is available as 1000 milligram. The companies which have it are named Deflon, Aldosmin, Desoflav, one more, Venosmin, one more, from Smart Pharma. I don't remember the name. So okay, these are the four. And the problem with Venusmin, they are selling it to general practitioners. Most of the clients are GPs, and they will come and tell you 150 milligram twice a day, which doesn't work. It has to be 1 gram, 1000 milligram, 3 times a day for 4 days. Start one day before surgery. Then twice a day for 3 days. Then once a day for 30 to 60 days. It will really improve.
So routinely in all surgeries, after all surgeries you advise?
See, I give it especially for hemorrhoids, sometimes for fistula, and also for fissure, because the edema becomes very less, the pain becomes less.
In every case you go for flavonoid.
Why not? I'm not using antibiotics, so might as well give something to reduce the edema.
Can we give pre-operative?
You start see, actual thing is, if you have a bad hemorrhoid, you start immediately on it, and then you take up. The question you should have asked me, if the patient has large hemorrhoids, grade 4, when do we operate? That's the question you have to ask. So when do you operate? Grade 4 hemorrhoids which cannot be reduced, when do you operate? Good. Main question to you.
Immediately operate.
Okay. Immediately, what are you going to do to make that go inside?
Highlight injection and open surgery.
So, if you want to operate a grade 4 hemorrhoid, use injection highlights, use up to 6 ampules. Don't worry about the ampules. Plastic surgeon uses 200 ampules during liposuction. 200. I'm saying only 6. When you see it, you will be breathless because it becomes very small. And once it becomes small, it goes in the anal canal, and then it's easy for you to take a pedicle stage. Okay, you can do it in it. Yes. Previously, we used to give Maxel, head load, diltiazem, and enzyme preparations, and that used to 2-3 days, then it was not coming. Now this immediately. Second, grade 4 if it's thrombosed internal and thrombosed external, don't get worried. It does not bleed. You will not even bleed one gauge piece because everything is thrombosed. So you stick very close to the edge. Otherwise you will take too much tissue out. You have to preserve the enoderm in grade 4. That's the only thing you have to remember.
Thank you.
Okay, I think next chalu karen because
Light up.
Moving on the next topic, that is video of laser hemorrhoidoplasty by Dr. Naresh Chauvatian.
So this video is repetition of sir's video, that is FG Hall and laser hemorrhoidoplasty. And another video is Chiutia procedure along with laser. So in this patient, presented with 2nd degree piles, and also patient has chronic fissure at 6 o'clock. So my first procedure was excision of fissure bed at 6 o'clock with at 9 o'clock laser internal sphincterotomy. It was done first, then I had done FG Hall and then laser hemorrhoidoplasty. So first step is ligation of the branches of the superior hemorrhoid artery at all palpable places. Generally, you can able to palpate at 4 to 6 places whenever there is a enlarged piles. So figure of 8 stitch is taken 1 to 1.5 centimeter above the upper border of piles. So that is roughly around 4 centimeter above the dentate line. With the Vicryl 20 5/8 circle needle, take some fiber of internal sphincter also as to catch hold the pedicle, and it will also fix the pile mass. So at the 7 o'clock you again palpate with the finger and take a similar stitch with the Vicryl 20. All palpable branches should be ligated. So this will stop the vascularity of the piles. That is, hypervascularization theory is corrected by this ligation. And then at anteriorly when you taking the anterior suture, rotate your wrist. So this is shown how to rotate your wrist and how to take the interior stitch in FG hole, in Tutor procedure, and in MIPH also. So first step is over, and then second step is laser hemorrhoidoplasty by using conical laser fiber. The fiber is entered from the anocutaneous junction at the lower part of the anodum, and then in fan shape manner you give the laser energy all around the pile mass, straight 30-degree upward, 30-degree downward direction. You rotate the fiber and apply the laser energy as to cover all areas. So at the end of this, you insert the ice finger for 1 minute, keep it for 1 minute, and then again do the process at another place. So this is at 11 o'clock. This is a conical fiber, and I am using fiber only. I am not using hand piece. Previously I was using hand piece, but now I have more comfortable with using bare fiber. Bare means without hand piece, not bare. This is a similar repetition at 7 o'clock. So initially you insert the fiber until you have taken the stitch, that is axial stitch, and then slightly withdraw the fiber and then start applying the energy. So best piles are flat piles, not very pedunculated piles for the laser. So this much is incision, and this patient will have very less pain in spite of 2 procedures done in a single patient. And another video is Tutor procedure. 2 rows of circumferential suture followed by laser. So in this patient, patient have almost circumferential piles with large and small piles, accessory piles in between. So whenever the patient have circumferential piles as primary and accessory piles, in that case you can do the Tutor procedure, or you can do the MIPH, that is stapler. So take the 2 row of circumferential suture, that is Tutor procedure, and followed by do the laser. The role of laser is large piles is taken very nicely, and regression is very good. So this will minimize the recurrence. So this is an insertion of the Tutor's proctoscope. This is a light illuminated proctoscope, and use your laparoscopic LED light and attach the cable with this instrument. So this will give beautiful inside view and beautiful illumination while taking the suture. So take with the vehicle 20, take the mucosa, submucosa, and some fiber of the internal sphincter. The first row is roughly 2 to 3 centimeter above the dentate line. It is a circumferential double interlock suture. Don't tight too much the suture, and don't keep it too loose. It should be just oppose at the mucosa. So first row is completed, and again the knot is tied. It is not similar to MIPH. In MIPH, during every suture we used to withdraw the scope, and then again we insert the suture anoscope. And in Tutor's procedure we continuously rotate the proctoscope, and the second suture should be from where the exit of the first one. So immediately at the exit of first one you take the second suture. And this is the second row is completed. You can start anywhere from 6 o'clock, 3 o'clock, 9 o'clock, wherever you are comfortable. But only thing is it should be completed. And at the end, rotate the endoscope and look for any bleeding, any sputter or any hematoma. If there is hematoma, press for some time, and at the end of procedure you insert the ice pack, so that will also help in regression of the hematoma. And then after completion of 2 rows of the tube test procedure, this is a laser hemorrhoidoplasty. In this there is hand piece is there over the conical fiber, and in fan shape manner you give the laser energy. Small piles will be taken care by the tube test procedure. Only bulky piles you need to do the laser as to assist in fast regression and to prevent the recurrence. So straightway insert the fiber up to the suture line, then slightly withdraw the fiber and start applying the energy. Slowly you withdraw the fiber and apply the energy in a continuous manner. And at the end of each pile's ablation, you insert a ice finger for keep it for 1 minute, and then again do the procedure at another place. So this is at 7 o'clock. Remain in the submucosa. Don't go too much deep or too much superficial. There should not be any mucosal damage, otherwise the patient can develop submucosal fistula or submucosal abscess. This is anteriorly at the 11 o'clock. With the handpiece, sometimes you find difficulty in insertion because the bulk of the entry will be increased. If you are in submucosa, then the movement of the fiber will be very easy. And if you are in the wrong plane, then the fiber will stuck and don't go advance. So remove the fiber and reinsert in the submucosa only.
So our next talk will be by Dr. Nitesh Jawar sir on the laser in fistula and left.
So is it any clearer than before? Is it better, sir, now? Sharpness, light one karke dekhte hain. Yeah. All right, so good morning once again. Now, see, in fissulas, the use of laser is limited, and most of us, we either don't want to accept this fact or we give in to patient's demand. And that is one area where it can cause a lot of problem. Because your patient comes with a very different expectation, no surgery, no scar, going home the same day, and there is a short recurrence. And somehow, most of us, when we are giving in to patient's demand, somewhere in our mind and heart we know that this person may have problem, this may recur or it will not heal at all. So, where exactly you will use laser? One. Secondly, if you laser as an independent tool to treat fistula, it's a very weak one. Never use laser in isolation. It has to be hybrid always. That you should remember. all the time in your mind when you're taking up fistula patients. We all know the classifications. We grew up reading about the Parkes classification, and now we have this university classification, St. James, which we usually get in our MRI reports. So I am going to talk about combining laser with lift technique. Now if you look at the technique, which is ligation of intersphincteric fistulous tract, in itself is a very good way of treating fistulas, especially if they are transsphincteric, one. Secondly, if the tract is mature. Now if you have a transsphincteric fistula and patient has just recovered from an abscess 3 weeks back, then definitely, in spite of having a good transsphincteric tract, you may not be able to tackle the tract because it is not mature enough to take sutures to hold the laser energy, and it can ultimately give way. So these are the conditions where you will use laser in transsphincteric one. If we look at the fistula as a whole, what are our options? The first one which came in vogue is FILAC. That is the ligation of this fistulous ablation, tract ablation. And this laser ablation of fistulous tract, though there was much hangama about this, but ultimately it did not stand the test of time. And now none of us are doing FILACs. I don't know if anybody is doing FILAC in the audience. Anybody does that? Koi karte hai FILAC? Nobody is doing that. So earlier results were also encouraging, but then as you follow these patients, they usually have recurrence within 3 months of the procedure. The other thing which you can do is DLPS, that is the slough, combining it with laser, or you can do coring with slough. You can do a primary fistulotomy with distal laser, or you can proximal, or you can do a lift with laser. Now these are your options depending on the fistula type, the maturity of the tract. You will decide which one you are going to take up, one, and how comfortable you are doing these procedures. Otherwise, in simple fistulas, like Mithal sir said, you're okay to do even fistulotomies and fistulectomies using laser fiber since your patients demand it. But when it comes to laser, don't try to use it in a way when we use it for the longer tracts. That is just ablating the tract. If you feel a fistulectomy is better, use a bare fiber and go ahead and do that. So what are the consideration? Internal opening, external opening, the branching pattern, length, depth, and history of previous surgery, and what is your patient's expectation. That is one of the most important things you have to keep in mind. You need to talk to the patient about the expectations, and if the patient is not willing for a conventional surgery, and if you have done laser, then this particular patient can land you in trouble later because he will have a completely different expectation. As I said, I am repeating it again, don't use it in isolation. It has to be hybrid always. There is no exception to this rule. Whenever you are doing a procedure where you are saving the sphincter or you are not completely excising the fistula, it's mandatory to do MRI or endoanal ultrasound, whichever facility you have. Now MRI that way is a much better investigation because again, endoanal ultrasound will have its operator-dependent biases, and unless you yourself are doing it, it is better to send the patient for MRI and then have them draw a picture of the tract on a stencil so that you can make it out where the external and internal openings are and what is the branching pattern of the fistula. Now this is how the diagrammatic representation of DLPS looks like. So if you see, this is the tract which is sort of transsphincteric. What you do, you just go submucosally, remove that particular part and then ablate the distal part of the fistula using laser. Now this slough, the principle is that the cryptoglandular complex in 80% of the cases is submucosal. In remaining 20 to 25% cases, it is in intersphincteric space. So if you are disconnecting the tract at submucosal level, then you are pretty much taking care of the cryptoglandular complex, and you can use that particular slough thing or the mucosal flap which you have removed as a flap to close the opening, and that can solve the problem as it will disconnect the tract from the feeding of stool from the anus. Now, when we talk about lift, like I said, it has to be transsphincteric. If you are looking at the James classification, it should be 3D or E with or without abscess, but transsphincteric. You will ligate the tract on the internal sphincter side. Now, if you look at this particular diagram, so here somewhere you have to ligate the tract. The best way is to remove at least 0.5 to 1 centimeter of tract. Ariva, thank you so much. And if you resect and send it, you are very sure that you are removing the intersphincteric gland or the cryptoglandular complex. Scooping, laser irrigation, they are again integral part of the lift technique. Please keep in mind, when we are doing it, many a times the tract is not mature enough and you lose the end which is connecting the two internal and external sphincter sides. That time, it is important to ligate both the sides. Best way is to transfix. So if you get a ligation towards the internal sphincter side, it is better. The external one, you can always take a transfixation suture and close it by using preferably a PDS, which is a long absorbable suture. So this is the area which we are tackling in lift when we are doing it. These are the areas where we expect the cryptoglandular complex to be. So when you are combining lift with laser, before disconnecting the tract, if you can ablate the tract like we used to do in PHYLAC, then that will take care of the internal opening, cryptoglandular complex, and the remaining external tract which is going all the way to the skin. And then you can go ahead and perform lift procedure. So ablate it first, then disconnect, and after the ligation. Now this is one video where we are doing this procedure in a female patient anteriorly. All of us know that all these fistulas which are in anterior compartment, we consider them as complex and they have a risk of causing some incontinence if not complete. So it is better to do sphincter saving procedures in these patients. If you can cannulate the tract by putting in a probe, that is your best chance, because then the chances of losing the tract are almost zero. You dissect around the probe and using a right angle or a mixture, you can create enough space in and around that intersphincteric area so that the tract can be seen easily. Now this particular tract, again as I mentioned, when you are seeing MRI, you should look at the depth of the tract from the skin surface also. Sometimes it may be very high up in the intersphincteric zone and you may not be able to reach it. So that particular consideration you should keep in mind before embarking upon these procedures. Once you've gone around the tract, you can loop it on both the sides towards the internal sphincter as well as towards the external sphincter. As I said, it is important to ligate the tract on the internal sphincter side, that is towards the anal canal, and the later part, even if you cut and the suture slips, you can take a transfixation suture in the external sphincter. But internal one, if you try to ligate, it holds better and the chances of leak afterwards are less. This is how the laser is being done. Again, to take care of the external component or the distal tract which we have left behind. You have the options of doing a coring if you are considering only lift and not laser. Even that can be done. You can completely excise the tract outside the external sphincter and close the area in between the external sphincter without causing any damage to the sphincter complex. If you have a long tract, again the same procedure. The only thing is you have to make enough efforts to get the tract right. In this particular case, you can see it is a 6 o'clock posterior fistula. Most of these patients may have horseshoe extension, so you have to exclude that possibility before you take up these patients by doing MRI. Second consideration is the depth from the surface. Again, posteriorly, if you look at the sphincter complex, it is notorious one because the post-anal space sometimes can create problem. There is some pad tissue in between the two sphincters also there. So if you lose this tract, then it can create a lot of problem for you. It is better to railroad the feeding tube on the probe and then only pass the laser fiber so you don't lose the tip in the bargain. Like we were discussing, when we are using these radial fibers, sometimes the glass tip may break inside. Just imagine if you lose the tip in this particular patient, it is going to be a nightmare. If you lose it in a hemorrhoidal tissue, you can go ahead and do a hemorrhoidectomy. Here what will you do? You will have to actually search the tip and remove it, or probably convert it to a complete fistulectomy. So now, rest of the procedure is more or less the same. And re-emphasizing, before ligating this, you should fire energy from inside out in such a way that you take care of the internal opening, the cryptoglandular complex, and you come all the way out the external sphincter side towards the sphenoidal fossa. And then you can finish this procedure. So this is how we mount the laser fiber inside. And usually when we are doing fistulas, like we talked about the energy which will give in hemorrhoids, here also we need to limit it to 100 joules per centimeter. The withdrawal of the fiber should be in a uniform manner so that it doesn't get stuck at one point for a longer time. Otherwise it will burn the tissue. Now these are a few cases where you get distinct advantages if you compare them with the results of any other procedure. Here definitely, whether you're doing a laser, you're doing a lift, you're doing a waft, if you are doing a sphincter saving procedure in these patients, one. Secondly, you are taking care of the tissue around this. You can have these long fistulas. See, this guy had a fistula which is coming all the way up to the upper thigh. And just by doing a lift and this kind of a procedure, these are the end results which we get. This is another patient where and we did that, and this is the healed wound. It looks like this later on. In between the skin and other tissue is preserved, and these patients are the ones who are going to be benefited maximum by this particular procedure. When you are considering the surgery, when you are discussing the options, even when you discuss a chance of a recurrence in such cases, their likelihood of deciding for this procedure is even more. They will not mind that if it fails, they can go for a definitive surgery later on. Biolift is one of the modification no longer being used because it's costly and doesn't offer any additional advantage over lift. So like I said, wavelength does not change. When we talk proctology today, it is 1470 watt, 10 watts for these tracks. If you have a very thick tract, you can go up to 11 or 12, but not more than that. 100 joules per centimeter is the withdrawal. You get a fair idea beforehand. Once you have put the probe inside, you know that this tract length is say 7 centimeter or 8 centimeter. Your total fired energy should not cross that. So if it is an 8 centimeter tract, it should not go beyond 800. Then you are doubly sure that you are not overheating the tissue in that area and destroying it rather than ablating it. Rotational movement of the fiber is one of the very important things when you are dealing with long tracts, especially the anterior ones, which are not very deep, but they are far away. You have a small anterior fistula which is opening up to the scrotum. Now, if you have this 10 or 12 centimeter long tract, if your fiber gets stuck at one particular point and you fire more energy in that area, and then it comes out with a tuck, then it will leave skip areas in between. So it will burn somewhere more and then leave tissue which is unattended and then again burn. So you have these skip lesions which will definitely cause problems. Smooth uniform withdrawal, I have already told you. Don't stay immediate cooling. If there is a long tract, now just imagine you have a long tunnel-like thing, and if you just ablate it and leave it like this, the laser's latent heat will keep on causing this burning effect over a period of at least 1 week to 10 days. Now all this tissue has to come out, so you have to provide drainage like we do by creating vein holes in our sewer lines in the cities. So every 3 or 4 centimeter you make punches in the tract so that there is a space for the debris to come out, and you can actually squeeze by rolling the gauze and take out these muck which we sometimes take out in bilateral sinus also. So that thing has to come out in your post-operative care. Please remember, all patients who are going for laser surgery will require very strict post-operative care lasting up to 3 to 4 weeks. So patients who are coming to you from outside, they want to go back, you have to be very cautious. If at all you have to do this procedure in a patient who is not going to stay with you for long, it is better to do a fistulectomy rather than offering them this particular options. Scooping again is one of the very important factors whether we are doing bilateral sinus or fistula, so that you remove all the muck which you have created by burning, ablating it by laser. And disconnection of the tract is of utmost importance. So we always inject methylene blue so that you don't lose the tracts. Sometimes there are side branches, sometimes even in bilateral sinus you can make a completely false passage and ablate something which was not the sinus. It happens. It is better to define the tracks and then do it, and provide proper drainage. So if there is an external opening, make it as wide as possible. If pouring is required, that can be done. And then these patients, with the help of lift and laser, will do well. Now I said about the distal laser and proximal fistulotomy. Kushal sir, can I touch upon this, or you are going to take up? I will do it. You'll do it. Okay, fine, no problem. So I'll leave it here then, because most of the other things are related to that only. So the remaining talk Kushal sir is going to do, so I will not talk about this. This is my slide.
Okay. Thank you, sir. Any question from the audience about last lecture?
How the methylene blue will be helped? You're telling that injecting the methylene blue.
Alright, so sometimes what happens that when you are trying to push the probe, it will not go in, right? So you are completely dependent on the strength of the tract there. How we say when you are not seeing an internal opening, all you have to do is you keep on pouring, and once you give a tuck, you can feel a dimple inside, right? So if you inject the methylene blue and then go in the interesting place, if you open the tract by mistake, the methylene blue will come out, and that's how you will know that you are damaging the tract. One. Secondly, after ligating the cut, you should see blue on both the sides. So even if you are not able to probe it, it is better if you have injected methylene blue before disrupting the tissue. It always helps. So be it fistula or pylorel sinus, this is what we follow. Anything else?
Sir, what are the chances of breakage of fiber? Because this is glass fiber. Why are you rotating the fiber, glass fiber?
Right.
So, what are the chances?
So if you are rotating it, it will not break. The chances of breakage are more if you stay at one point, there is some carbonization at the tip, and the fiber gets stuck. Then what you have to do, if you are feeling that tuck, that it has gotten stuck somewhere, you fire the energy and try to withdraw. If you pull just like that, then the glass tip, there is a chance. That's what it has not happened so far, but if you are in that situation, you are in trouble. Yeah.
Okay. Thank you very much, sir. Thank you.
Okay. Dr. Nitish has covered PILAC. I'm going to cover it just a few slides to tell you something really important. Laser is not a magic solution. It's only an energy source like you have a cautery. With incorrect usage of laser, it can backfire. And you had it. And all your cases will come with time and they'll all be on your head. So, we have the focus on laser. Fistula surgery, the first line of treatment for fistula should be minimally invasive surgery. The fistulectomy is always there with primary sphincter repair. But when the patient is coming for the first time, try to give a sphincter saving surgery. Now, a lot has been said about the reason why I want to show you this. This is the gimmick used by all the laser companies to make you buy the machine. That, in a fistula tract, you put the laser fiber inside and you burn from inside to outside and then take a stitch in the anal canal. The fistula will heal. It doesn't heal. It will never heal. And that is the biggest problem. And we keep thinking just by burning this much, that the patient is going to be okay and this tract is going to close down. It is far from the truth. So PILAC, although it seems very easy, anybody can do it. You find the internal opening, you curate the tract, you wash the tract, and you put your laser fiber inside and you burn the tract, and then you close the internal opening. So what could be more difficult? Nothing. So this is the laser fiber which goes through the infant feeding tube, And on your way out, at 10 watts per millimeter per second, you activate it and come out. And then clean it out. And then you take a stitch, a figure of 8 or circumferential stitch around that hole, and you close it, and you know it's tight and it's going to take. But it doesn't work. So this is pulling the probe out and tightening the suture. So we know that we have really tried the right place and the right opening, and it should hold. It doesn't. All of these patients come back to you saying that they have a problem, and you even tried methylene blue, then methylene blue doesn't come in, and you've taken out a bit of external opening so it doesn't prematurely close. So pitfalls is a blind procedure. The tracks are not visualized. Many skip areas. Internal opening is not managed adequately. Fissure tracks are tortuous in multiple planes. Associated abscess, multiple tracks, multiple internal and external openings. The branching track cannot be adequately addressed, increasing the power of laser could result in damage to the sphincters. Now, see the series. 5 lakh. This is the success rate they are claiming, but actually it is 33% or less. Even we have it here. This is our study. But actually, if you ask me to put my hand on my heart and say what is the recurrence rate, I would say 100%. So please don't think of 5 lakh when you're buying a laser machine. I will teach you a technique which is almost foolproof. So regarding 5 lakh, let's not go. You can read it yourself because Nitisha has already covered it. It's not magic. Surgeon feels that the closure of the internal opening occurs on its own due to laser energy shrinkage effect, and hence no closure is required. It's not true. And the shrinkage effect you're talking about, it doesn't occur. When you are dealing with a fistula, the only thing you have to really concentrate is on the internal opening. Everything else is extra. You don't need to do anything for it. You can just simply curate it and that's enough. But if you manage the internal opening correctly, then you will start treating fistulas. Complete removal of the primary infection is the only way to prevent a recurrence. Hence, primary excision of the internal opening is recommended. So we have different types of procedures. The last one is what I'm going to be concentrating on. So you have the internal opening here. Okay. Now you're going to do a procedure to manage this internal opening. So you cut out this much. 5 millimeter margin is excised of the internal opening up to external anal sphincter from inside. So what you're doing is you're taking out the mucosa, some mucosa and internal sphincter, 5 millimeter circle and going up to the intersphincteric space. The biggest problem our surgeons are having is the fistula is moving around in the intersphincteric plane. So you have a fistula, you see it's at 6 o'clock, no problem, internal opening at 6 o'clock, but you have a horseshoe in the intersphincteric space. So what do you do? Where do you approach it from? You approach by taking out this inside portion. The moment you take this out, you have the space between the internal sphincter and external sphincter. You have all that space. Just put a curate in and curate it out. You have a laser fiber, after you have curated it and washed it, put a laser fiber inside on both sides, burn it. That's all. And if you have an abscess with extension which is going up, you have already taken this out, so you can curate this portion, which is quite easy. And the defect in the external anal sphincter is this. What you do is you curate it and then you close it with PDS. This is closure with PDS. Now can I show you this? I'll show you 2 videos in which it's clearly shown how to do it. You see the external opening is up here, and the internal opening mostly is at 12 o'clock. Sometimes it comes at 6 o'clock. So hydrogen peroxide is coming from 12 o'clock. You put in this infant feeding tube. Now this is excising the internal opening. You stay 5 millimeters away. You can use laser to do it. You can use cautery to do it. I personally like laser more than the cautery, but I make the mark the area with cautery, and then I use laser. Why I use laser? Because it is very defined, 2 to 3 millimeter depth, and you can remain very close to the internal opening. So see, this whole thing will come out. You have excised it, you have taken the adequate margin, you have taken out the internal opening and the infected tissue. Once you have done this, everything else is you can manage by laser. So if you are using laser, this is the best way to go. So you put the infeeding tube on top of it, and then through that you put the laser fiber. The laser fiber comes in at 12 o'clock, and on withdrawal, you have already curated the tract. On withdrawal, you burn the tract. And that's not it. Again, it's not a magic solution. After you burn the tract, you curate it. Curate it really nice till all that black stuff stops coming. And then you do one more round of putting the fiber inside and burning it. And you muscleize the internal opening, so it doesn't close prematurely. The musculation is not to prevent the wound from expanding, it is prevent the wound from closing. If it closes prematurely, then you have a problem again. Now this patient has an internal opening which you can see at 6 o'clock, and has intersphincteric, is going up intersphincteric both sides, towards 3 o'clock and towards 9 o'clock. So how do you do it? You have felt it, deep intersphincteric space, you put in methylene blue, you have stained it, and now you are cutting it. See, this is how you actually cut it out. And once you have cut about 2 millimeters or so, you can hold it with Ellis. So that whole thing has come out. You have access to deep intersphincteric space, you curate that area, you wash that area. Curating is of utmost importance to take out all the abscess and interstitial tissue. And after doing all that, you pass in the laser fiber. And then you can pass the fiber towards 3 o'clock and towards 9 o'clock. So this is towards 9 o'clock. And the tissue which you have cut out, you need to just muscularize it. Now, it is simplification, and it is as simple as you see it. But the thing is, we don't want to venture out. The first one you do, you will have some difficulty. What you have to do is, you have to give saline adrenaline, inject it in the surrounding tissue where you're going to cut. This is a very vascular area. You wait for 5 minutes, mark it with cautery, then use cautery or laser. Take the lower edge. Once you take the lower edge, you can hold it with Ellis, and then you lift it. You see the plane coming. So that is a part of the fistula. Remain very close to the fistula and take it out. I'm combining both my lectures. Now this patient has an anterior opening. See it again, how it's cut. And I thank Dr. Kamal Gupta for his videos. You're lifting it. And then you do laser of the tract. And then muscleize the edge. Both the edges, take a few vicryl 20 or 30 sutures. Then you close the external anal sphincter defect with PDS. You've got a probe inside and you're taking around it. So you've closed the external anal sphincter, you muscleize the internal opening, and you've done the laser of the tract. Now this 50-year-old male is a problem which is occurring a lot with people who have lasers. They are operating short fistula tracts, which are intersphincteric tracts, with laser because the patient is demanding it. All the patients I have got are from aggregators. So they have done it because the patient is demanding, I want a laser. Remember, if you have an intersphincteric fistula, which is low, please only do a fistulotomy. And do the fistulotomy with laser. That's not a problem. But you start doing phylac in them, they will all come back like this patient. So the patient came, a small fistula was there from here to here. Now he has an abscess there, intersphincteric abscess, just because that was taken out with laser. So that's how it looks. The principle remains the same. Take out the internal opening. That's the saline adrenaline. How do you make saline adrenaline? Take 100 ml of saline and put 1 ampule of adrenaline into that 100 ml. You don't have to count the drops. It's just plain 100 ml of saline and 1 ampule of adrenaline. See, mark it out. And if you think it's quite bleedy, then use a bipolar for sense. But don't use too much cautery there. And since this patient had a laser before, the first thing he said was, don't do laser in mine. Do it like you would do a routine case. So that's the amount of tissue which is taken. You've taken all that out, curate it, go up. You have space in the intersphincteric space to go up. Clean it out. Then you muscleize it. And you'll be surprised to see the amount of tissue which comes out. That's how it is after I finish, and see the amount of tissue which is there. So that tissue. Now I did a similar case in a 40-year-old male and they got a similar tissue which came as adenocarcinoma, and he has been operated twice by laser before. So are we missing things? We have to take the right step. So how do you excise? What is a central disease? I'm going to show you in schematics. You have the internal sphincter, you have the levator and the external anal sphincter, and you have a fistula which is going through both of them, transsphincteric fistula. So the first thing is you core out. Like I said, you core up to the external sphincter. And once you've cored out, that space is left. And you close the external sphincter there. And you can muscleize the internal sphincter. That's basics. And the distal tract you can manage by WAF, you can manage by laser, you can manage just by curating. Or you can use Fixition. Fixition is a device which does coring. It's a beautiful instrument. You put the instrument inside, see, you put this instrument inside, That is the base plate, and then you cut over it. And you cut this whole tract. And then you close the external sphincter and musculize the internal sphincter. So, let's skip this. Now, this is a long tract. Now, we will see that you get a lot of patients who have squattal fistulas. And you start, we know what to do. We put a catheter in and we start cutting from the squattal end and we go all the way to the internal sphincter. But can you do something else? So this is the fistula, that's the penis, and you have on both sides the scrotum, that's the tract. First thing is excise the internal opening, then put a laser in and laser ablate the whole tract and increase the size of the external opening, they will heal. This is the same one I showed you. So the principle I am showing you now, and excising the internal opening is a mainstay. I was wondering where this video went. And this is the internal feeding tube loaded. Laser fiber goes in that. Reload the laser fiber for ablation. After ablation, you close this. Now, we talk about radial fibers. Let's talk about bare fiber in fistula. Now, the patient has a fistula. I am doing a fistulotomy or a fistulectomy. I use the bare fiber. Do you see any charring here? There's no charring. It's absolutely clean. And that's why these patients heal very, very nicely, because there's lack of charring which happens when you do cautery, and they heal really nice. Two fistulas. That's one. And you know you can't cut the sphincter at both the sides. So, at one side, this is with laser. I said you can do it with laser. You cut out the internal opening. And you have not touched the external sphincter, just the internal opening you're taking out. And when you give a traction, you see the whole tract comes out. So that's after excision. And I've put in a fixation device and I cut the tract out. And then you close the external anal sphincter inside. That's the external anal sphincter. I have spared the external anal sphincter, just close the defect. That's the other one. One I have dealt, and the other one was very superficial. So do a primary fistulotomy. Don't go with phylac. Just cut it like you would do a fistulotomy with a cautery. Do it with a laser. Patient is happy. You are happy that you have not compromised on the procedure. And then musculize it. So those who are interested to learn more, you can come to IMAST. The next one is very close from tomorrow. But if you're really into it, you can come. I think there's 1 or 2 seats vacant. We have intake of 30 students. They come from all over India. And if you want further reading, so we've got 3 books out. One is Lasers in Proctology, then Atlas of Anatomy of Anal Canal, and Operative Proctology. If you buy both these together, I think they cost 3,500. And it's really, really good. Because everything I said is there in the book. Dick, anything else you want to know in fistula? Fistula is endless.
Any question regarding the last lecture?
10 years back, I was called in Calcutta Medical College for a workshop to operate. Dr. Sukumar Mehti was the head of department. So I did my cases and he did a fistula. And the first thing I saw was he was doing fistula from inside. I said, these Bengalis are एकदम उल्टा, अंदर से operate कर रहे, बाहर से operate करना चाहिए. And since then I've told him many times, he was doing the right thing, we were doing the wrong. We always approach the fistula from outside. Stop doing that. Approach the fistula from inside. Outside, say you spent 1 hour reaching the external sphincter and you said, बहुत हो गया, छोड़ दो. कुछ नहीं होगा, इतना तो निकाल दिया. What you took out was useless. You just take out the inside part, rest you can be assured it will go up because the fuel to the fire is gone. So the fire will die out. Okay, so start operating your fistulas from inside, from tomorrow. You may encounter some problems like bleeding or confusion. Don't be confused. The internal opening is there. If you are really confused, take a probe from outside to inside and cut around the probe. Okay?
Yes, sir. Thank you. Thank you for the golden words. Now, sorry? પૂછો ને આપણે આજ કરવાનું છે. No time limit. Meanwhile, we will just arranging the inauguration function. Dr. Basir will do. You continue, please, sir. We will continue the question and answer and also the simultaneous preparation.
Because while managing transphyteric fistula, you told that studying the internal opening along with internal sphincter and external sphincter.
Yeah.
Now, what is the philosophy behind marsupialization of the internal opening? Because we have
so
already,
it doesn't close.
Okay. Because the epithelial is concerned, it is more when you either leave it or suture it rather than marsupialization.
Marsupialization is to prevent it from closure.
Only 10 minutes.
I am preventing epithelialization.
Only 10 minutes.
It will come out after 10 days, so sutures. You can take it out also.
Okay. So marsupialization will not add in recurrences of the disease.
No, it will prevent recurrence.
Okay. And second thing, marsupialization at 6 o'clock. 6 o'clock position. Does it form keyhole surgery as far as the...
It doesn't because you're not going up to the anal verge. Okay. If you were cutting through the anal verge, yes, it can cause.
Okay, thank you.
Okay, there is one take-home message which I didn't say in my fistula because I was talking about transsphincteric. For intersphincteric fistula, you operate from inside, not from outside. Intersphincteric fistula could be up to dentate line, it could be up to anorectal ring, or it could go higher up. It doesn't matter. You operate from inside. You put a probe inside and cut over the probe. All the way down, all the way till anorectal ring. All those 4 centimeters up to anorectal ring can be incised. Incise it, use cautery and curate it. That is cured. You do anything else is not cured. Okay.
So should we give a small incision over the anal verge also to drain out?
Okay. I didn't want to say it because I thought people won't understand. So you have excised from internal opening to anorectal ring. So all that kachra is going to come down. We need a gutter niche. So you from that internal opening to anal verge, you cut down. So full gutter comes down, everything will close and marsupialize. It should not close prematurely. Cure it well, marsupialize. Use laser to do it. Please.
A little silly question. When you do formal or standard fistulotomy or fistulectomy, what are the sphincters you can severe cut?
When you are doing a
how is it like out of the internal and external sphincter? When you do a formal sphincterotomy, sorry, not a fistulotomy, and maybe a fistulectomy, which are the sphincters you can compromise by severing or cutting? Which won't give you the incontinence?
If you are below the dentate line and the amount of muscle involved is 30% in females and 50% in males, you can sacrifice both the internal sphincter and the external sphincter. If you are higher than the dentate line, that means more amount of muscle is involved, then you can sacrifice it, but you have to close it. You have to do a primary sphincter repair. You sacrifice. That's the main way. It's called fistulectomy with primary sphincter repair. Okay? पेन है पेन okay these 4 fingers these 4 fingers are the sphincters, 25%, 50, 75, 100. Now you're holding it, this is the anal gland and is holding it. किसी के पास पेन है तो ले लो. Then only you will understand what I'm trying. If you have a pen, करो, नहीं कर सकते हो तो बगल वाले को दे दो. Okay? Now pull. Then you pull it down, you can't because you are holding it tight. Now cut 25% of sphincter. Pull it, it's still intact. Cut 50%. It shakes a bit side to side. So that means flashes and maybe liquid stools. And when you take that out, it becomes really wobbly. That means you are going to create incontinence, but still, it's not total incontinence. Solid stools ko nahi hai. When you cut the anorectal ring, this whole thing will go and then you have incontinence. That's the rule you were asking.
Excellent demonstration. Excellent. Now I will forget this one. Can we proceed for the
First you have to turn this on. क्या होता है मैं बता रहा हूँ.
फोटो में
पुराने फोटो थे ना.
हाँ. अच्छा तो इनको यहाँ रख देते थोड़ा. बंद कर
ये रख दो.
हाँ. हाँ पुराने फोटो में आ रहा था बराबर. आपका अनुभव सर.
अरे तुम्हारी फोटो. I was a secretary and I said कितना अच्छा फोटो करा हो.
भाई आप बंद कर दो. लाइट बंद कर. So I like to invite for the inaugural function Dr. Mittal sir, Dr. Nitish sir, and our SSS President Dr. Qureshi sir and Secretary Dr. Hirian Vedi sir, and GSA President Dr. Naresh Arora sir, and GSSA President Dr. Naresh Mehta sir, and our Senior Surgeon Dr. Sawani sir, Himmat bhai Sawani please, and then Navadia sir please come. Please sir. सर मैं तो माइक करूंगा. नरेश नहीं सर दोनों में से एक चलेगा. भाई लाइट म्यूजिक बगाओ. आरती I like to invite Dr. Mittal sir for felicitation, and Dr. Basir sir please give some memento and some gift from the Surat. સામેથી ફોટો પાડ સામેથી. थैंक यू सर, आपने जो समय दिया, नॉलेज दिया. थैंक यू. कुछ कहना चाहेंगे?
I feel the only way to progress is not by doing a large number of cases, but learning to do it well and learning the right way. Then only you're going to go up. You just think numbers are going to make a difference, it doesn't. Because after a certain time, you've got what you've got. You're doing 10, 15, 20 cases a day, but you're doing it like you did 30, 40 years back. You need to improve. So I think Bhavin and Naresh have arranged a program in which it's enlightening for everybody. I think everybody took back some message of how you can improve your surgeries. Thank you so much for inviting.
I like to invite Dr. Nitesh sir and I like to invite Dr. Naresh Mehta sir to facilitate him with bouquet and gifts. This CME was organized with support of Surat Surgeon Society with accuracy, and we have two presidents here from the Gujarat Surgeon Association and Gujarat Surgeon Society Association, GSSA and GSA. So I like to invite Dr. Mehta sir, Dr. Naresh Mehta sir, and Dr. Naresh, please facilitate him with a bouquet. Both Naresh. We have another Naresh also. Third Naresh. Just line up. I like to invite Dr. Naresh Arora sir and Dr. Basse sir will facilitate with a bouquet and token of love. We have Dr. Qureshi sir, President of the Gujarat Surgeon Society, and I like to invite Dr. Vimal Vyas to facilitate him. Please, Dr. Vimal bhai, please come on stage. And last but not least, Dr. Hiren Vaidya sir, please come on the stage, and Dr. Shiva, please facilitate him with a bouquet and token of love. Felicitate. Poor English, sorry. भावना अच्छी है, words शायद गलत होंगे. And we'll complete the inaugural function now and we'll move on the next session of the CME. Thank you. Hello. अच्छा Fisher. Next session is laser in anal fissure by Dr. Nitesh Jawar, and this whole session is sponsored by Abbott company and we'll invite, before we start the lecture, we'll invite Healthium company's main person on the stage, and we'll facilitate by the Dr. Naresh sir with the bouquet and his talk of 5 minutes. Please give a round of applause. He has given a lot of support to us. thank you for the wholehearted support for this CME. And we'll take a small presentation from the company, sir. After that, we will start. For this session, after this, Dr. Naresh Mehta sir and Dr. Dakshesh Desai will be the chairperson. Dr. Dakshesh bhai છે ચાબી વાગ્યા છે.
Very good afternoon, sir, and all the dignitaries who are all present in this conference room. Myself, Akhilesh Singh, and I am a sales manager for Healthium Medtech Limited for Gujarat and Madhya Pradesh for both the states. And from Healthium, I am welcoming you all, sir, for this wonderful learning session. And I would be taking only a few minutes for you to just brief about what is Healthium is doing in this current scenario for all the surgeon fraternity and where we have started. So, sir, Healthium Medtech is first independent indigenous medtech company which is having complete 8 wholly integrated manufacturing facility which has been completely US FDA approved plant. And we have started our journey in year 1990 with the manufacturing of a very basic boards like say silk sutures and the gut sutures which is available in that point of time as a point of care. And slowly, gradually, we have been added our portfolio with the non-absorbable sutures as well as with the absorbable sutures. And then year 2000, we have introduced our hernia meshes for the hernia portfolio. Slowly, gradually, we have added our arthroscopy solutions, which has been available standard care with almost 50 US patents available as on now. We have been having our own presence in more than 80 countries, and we have been supplying the goods, and we have all the our manufacturing units which has been available at Bangalore Pinia Industrial Unit. We have been covering more than 80 districts, 98% districts, and as I've said, more than 50 plus patents which we have been already there with us. What we have been provided as an or get as an accreditation from the global perspective. So as I've shared with you, sir, we have been US FDA approved. Then we are the WHO GMP certified, then CE certified, and I would just like to highlight on one point of this EU NDR. This is one of the latest addition to our quality perspective, and this is one of the most stringent quality check marks available with the Healthium Medtech, and Healthium Medtech is the first in global to achieve this recognition, because previously it was European Union Medical Device Directive which was given some direction for the quality perspective, but now under the guidance of European Union Medical Device Regulation, now it is an act which has been in nutshell providing more efficacious product, more safety devices for the better outcome of your surgical specialty and for the patients as well, sir. And these are the some innovations, sir, which we have done. The first and the latest one, which is like the post-op surgical dressing with a unique patented technology which we have launched. Then we have an indigenously designed all the arthroscopy solution. Then we have a comprehensive ranges of sutures. We have our own indigenous ligating clips available from 100 to 200, and then we have an anti-maneuverable gloves also. So these are the comprehensive solutions, sir, which we have been providing to the surgeon fraternity. The sutures, wound dressings, surgical staplers, gloves, ligation in staplers, and hernia meshes. I'm sure some of you, or maybe many of you, sir, gone through this Crucin Plus. This is our antibacterial sutures. Then in Monoglide, Fast, PDS. You name the suture and it is available with us. This is one thing unique, sir, Truba, which we are having with us with a unique knot, triangular knot stopper. This is the dressing which has been available with the brand NXT, Therapter NXT, with the sizes small. The smallest one is the 6 by 7 centimeter till 10 by 35 centimeter we are having, and this is a unique antibacterial dressing. Again, this is true type, the ligation clip which we have with a unique knurling pattern design which will provide the more efficacious and more safety towards the grip. Last but not least, the Trulene mesh which we have with us, and time mesh for your all IBOM cases, sir. So this is in nutshell is all about Healthium, sir. Definitely I or maybe my colleague Mr. Bhagirath and Krunal based out at Surat and the periphery will definitely come and will discuss more about this. And I would like to thank Dr. Naresh sir for just giving us this opportunity, and the Gujarat Surgeon Society Association Surat has given this opportunity. Thanks and thanks once again, sir.
Now we'll proceed for
GSS.
One small formality. Please, Naresh Mehta sir, Naresh Arora sir, come on stage so we can have a picture.
Light.
Light, please.
Light.
देखा से हाँ बस बोलो
ये तो बात है आपला पेचिया ना दिखाई दो
ओके so this is a formality for some association procedure.
क्या बताऊं क्या जरूरत है
in between, I like to warm welcome of Dr. Vitesh sir from Ahmedabad and Dr. Bijal sir and Dr. Kaji sir. Give round applause for them, all of three. They are our friends. And we Ahmedabad surgeon and Surat surgeon are going to organize 2025 Acrosicon together, a national level conference in September 2025. So they are welcome from the Surat and Naresh sir. Done. Okay, done. Thank you. All of three Naresh.
September.
Now, Dr. Nitish sir, please proceed with the next lecture of the Fisher surgery with laser. Thank you.
All right, so Fisher, as all of us know, it is one of the simplest one. But Fisher patients are the one who will walk in your clinic with very first time they get problem. Your fissulas, piles and pyloral sinus, they may not come to you, but fissures will come to you very early in the course of disease because the pain is annoying and sometimes it is excruciating. So what causes fissure? A quick recap. It is a microtrauma which is causing pain, and due to that there is a spasm of the internal anal sphincter which is involuntary muscle, and once this spasm sets in, then there is a ischemic ulcer which is formed, mostly at 6 o'clock position or posteriorly, and that will refuse to heal. Now this particular problem can have some reasons behind it. One of them, we know it is an ulcer, but this is a kind of a ischemic ulcer which is not very well perfused. Two reasons which are given for this. One is by Lockhart memory is the shape of the sphincter, which is not completely circular but a little bit oblong, so that it is not well perfused both anteriorly and posteriorly, and there is more support on the side to the mucosa by sphincter. One. Secondly, there is less perfusion at 6 o'clock position, and these two conditions, they make it little prone to develop fissures at these two locations. Another thing, when they did a physiological study on these patients who were suffering from fissures, they found out that whenever there is the RAIR, that is the rectoanal inhibitory reflex, there is relaxation, which is followed by a prolonged contraction, which is very long in these patients, and that probably leads to the formation of fissure. Now, once the fissure sets in, I will not go into details of these two investigations. These are the only two things you will be doing. Mostly inspection. If you are lucky, then digital rectal examination. And if you are even more lucky than that, then proctoscopy. But most of these patients, they will refuse examination because they are in too much pain. And many a times we can't do any of these. But definitely you don't require any investigation to do that. Now, if you look at the location, 70% of the fissures are going to be in 6 o'clock position. In midline anteriorly, they are more common in females than in men. And sometimes you may have an anterior and posterior both fissures, which are in around 3% of the patient you will get this situation. Now, these fissures, we usually talk about acute fissure and chronic fissure so that we can decide when we are going to intervene. So how do we differentiate between the two? Acute can also be taken as a superficial fissure, and here you have severe pain and bleeding. You can see the separation of the anoderm, which is not going very deep, but the edges are sharp, and internal sphincter is not breached, so you may not see it open at the base of the fissure. And if you treat these fissures by giving pain relief and stool softener and some calcium channel blockers, usually they will respond to conservative treatment. The problem starts when you have deep fissures like this, wherein you have everted or rolled up edges. The ulcer is pear-shaped, and you can see the sphincter at the base of the fissure. You can see a hypertrophic papilla, you can see a sentinel tag, and these are the fissures who will refuse to heal by conservative management only. Even if they respond, they come back very fast. So the patient is, sometimes they will keep your prescription with them. Whenever there is a problem, they'll keep on taking it. And when you ask them, since when are you suffering, it may run in months or sometimes in years too. So, how do we grade the fissure? Now, very common question nowadays, whenever the patient comes, they always ask you about stage or grade, whether it is piles or fissure or whatever. So, in fissures, these are the grades where the earlier ones are towards the acute side, and the final one has got the triangle of a classic chronic fissure, where you have a hypertrophic papilla, sentinel tag, and the sphincter, which is exposed at the base. Now look at the recommendation, how we treat these fissulas. The mainstay of treatment is conservative. 90% of the patients will heal by conservative management. In between comes something bridging like botulinum toxin, and then on the other side, which is sort of a gold standard, is lateral internal sphincterotomy. This is kind of established that it is because of the high pressure zone in the area below the dentate line, and if you take care of that pressure gradient, then most of these fissures are going to heal following LIS, whether you do something to the fissure per se or not. So this is the algorithm which we follow, and again LIS is one which is the mainstay. Another condition which we see in elderly who have suffered from fissure for a very long time, and with time their muscles have gotten weak. They will have fissures which are extremely painful, but they are low pressure fissures. These are the patients who will do well with enocutaneous flaps. Any kind of a lateral internal sphincterotomy in those patients can make them worse. So there's this one thing you should keep in mind. Even when the patient is coming with too much pain, please try to do a digital rectal examination. Sometimes you'll be surprised that though the patient is in pain, you are still able to do a digital rectal examination very comfortably because the spasm is not there. Now these are the patients who will not do well with LIS. Now when I say lateral internal sphincterotomy, there are two ways of doing it. One is an open way, wherein you make a cut, see everything under your vision and make a cut. Or you do it blindly by using knife. You can use cautery, you can use laser, you can use any instrument to cut it without opening the skin, and you go in a blind way based on the stereognosis of your finger which stays inside the anus when you are doing this. Now there are two ways of doing it. One is conventional and another one is tailored. So when I say conventional, what do I mean by that? So usually if you see, this is the dentate line. If we are doing a conventional way, then we have to cut the internal sphincter all the way up to the dentate line. Sometimes you find that the pressure is not too much. The spasm is there, but it is not very tight. If you feel the sphincter, if you don't feel a lot of bulk in that, then you can do a tailored one also, which goes only up to the fissure extent, which may be little less than the dentate line, and this is what is called as a tailored one. So you decide based on the sphincter spasm and the amount of sphincter which is involved or has gone into spasm. Now, if we are using laser for this, since we are discussing laser, what we need is bare fiber, a proper handpiece, angulated one is preferable. You should be able to create a heat sink by injecting either commercially available locks with adrenaline, or you can also use the adrenaline mixture which methods are suggested, and you should be able to locate the intersphincteric groove properly. I'll just run a small video. Half of it is by Mittal sir, the open one, because I usually don't do open. So this is how you feel for the, is it running? Was it running? No.
Go back.
Yeah, I think it is. Let's see. Yeah. So this is a closed internal sphincterotomy here. From inside out, when you come, you can see this dentate line here where you can see a small papilla. You come out like this and it dips in the intersphincteric groove or at Hilton's line, and that is the area from where you are going to take the bearings from. You create a heat sink inside, that is submucosally, or rather we should be saying subanodermal, and then in the intersphincteric zone as well. Now, before you put this handpiece inside with the bare fiber jutting out, make sure that it is not going beyond the dentate line, and you make a small cut in this. Here we are using bare fiber and using a continuous current rather than a pulse mode. After going inside, which is perpendicular to anal canal, you shift by 45 degrees towards the external anal sphincter, and then just pull it outside, cutting the internal sphincter in the bargain. Now there are two ways of doing it. You can do it from outside in or inside out. We prefer from inside out. This is a open lateral internal sphincterotomy which is being done. So herein you make around a 3 mm cut, take out the sphincter, and then under vision by using a laser or electrocautery, whatever you want. Again, the bare fiber is to be used here, and you can cut this also, and that will give you a controlled lateral internal sphincterotomy. Now, there is an argument always that when we are doing these sphincterotomies in a closed way, there can be an incomplete division of the fiber, because you really don't have any objective assessment that whether you have cut the sphincter completely or not. If you want to avoid that, you can do an open sphincterotomy, and that will give you definitely the same result. Bare fiber can be used to remove these skin tags like this. You can spray the laser on the base of the ulcer or fissure to make it raw, and similar way you can take care of the papilla also, hypertrophic papilla, if there is any. So the tips which you should follow in this, again the same thing, the wattage is important. It should not be more than 6 or 7. 1470, as I have re-emphasized multiple times today. Continuous mode. The total energy for a LIS should not cross 100 joules. If it is 70 degree, it is 70 joules, it is still acceptable. But if you are going 110 and 20, then probably you have made some burn in the external sphincter, and that can present in the form of an erectile abscess later. Mucosal damage has to be avoided at all cost. Now, in this case, if you are doing a closed internal sphincterotomy, you have got submucosally or subanodermally, and then you are trying to deflect your fiber laterally, but you make a hole in the mucosa. It is better to convert this into an open then and there. Otherwise, you will definitely 100% of the time will have a small fistula there. So it is better to cut open and convert it into open at that time only. Moving from inside out is little bit easy, because laser, unlike any other cutting tool like knife, if you put your finger inside and you bring the laser from outside in, it will definitely have the capacity to damage your finger, one. Secondly, we are using a bare fiber which will have maximum current with energy at the tip, which can make a small hole in the mucosa. So going from inside out makes a lot of sense. So again, it is a matter of choice, but if you talk about safety, inside out is better. Always guide the fiber with your finger so you know the final extent of the fiber is not going beyond the dentate line. You have no business cutting over dentate line in these cases. We are just doing a LIS. Angulation has to be proper. If it is 45 degrees, then definitely you will be able to cut the sphincter in a desired manner. And immediately after firing, when you feel for the sphincter, you will get a feeling of a cooked meat at 3 o'clock position where you are doing LIS. If you press further, you will be able to create an indentation in the internal sphincter. Once you have done it, hold your finger there for a good 60 seconds. Because if you let go, the fibers, they have just broken, and there may be a formation of hematoma at that place, which can again lead to a small abscess later on. It is better to give pressure for some time and ice fermentation of the this ice finger immediately after doing this, and that will do the job. The complications which are associated with these procedures are incontinence, hematoma, abscess, fistula. The most notorious one is recurrence. See, if you are doing LIS, patient has already suffered for long. He has got from acute to chronic phase. It is better we treat the patient in one go. So if you are doing a proper conventional sphincterotomy up to dentate line and dividing all the fibers, this should not happen. If you feel that in your hands you're not very comfortable doing a cliss in these cases, do an open one, but at least cut the sphincter, and this problem will not come. This is the list of complications, but if you see the incidences, it is very less. They may have incontinence for flatus for some time. That also may be temporary, and within 3 months all of them mostly recover. So nothing major here, but if we don't do it properly, then we can end up in unnecessary problems like small abscesses and other things. Nothing life-threatening, but annoying for the patient. Thank you so much.
Thank you very much, sir. Any question from the audience about the fissure? One question I like to ask, if anyone not. If patient is having a fissure and there is no spasm and mild pain, what should be done for this patient?
So it is, see, you have to look at it in two ways. One is you are breaking the pain cycle. If it is a low pressure fistula and problem is only pain, try to deal it with local anesthetic. If the pain goes, then the problem is solved because you are not dealing with the spasm at all. Sometimes these elderly people, they are in deep trouble. They are almost crying with pain. But when you examine, you find that the sphincter tone is normal. Then an inocutaneous flap will definitely help.
We have
no
tried,
LIS.
We have tried in 2-3 patients flap, but
yeah,
the sutures and
they will always give They will always give way. Like Mittal sir said, even if you are doing marsupialization, don't expect them to stay for more than a week or so. But surprisingly, they do the job.
Okay. Thank you, sir. Next lecture will be the by Dr. Mittal sir. Before that, I like to speak few words from Dr. Pritesh sir for upcoming conference.
Hello, good afternoon everyone. I am Dr. Pritesh, and I am very much thankful to Accuracy to allow us for AccuracyCon 2025 in Ahmedabad with joint venture like Ahmedabad and Surat, Twin City venture will be there. Dr. Sadiq Kazi is with me, Dr. Vijay Kadia, and Dr. Bhavin and Naresh Bhai. We all are here, and we announced that in 2025 September, first or second week, date will be decided soon. We will have AccuracyCon in Ahmedabad, and I invite all of you. See, just I was surprised that only in small gathering we are here almost 60 to 70 persons, and AccuracyCon would be there in 2025. We would expect minimum 700 to 800, and I invite all of you. More, yes. minimum. Maximum would be more than 1,000.
Like to small correction. Here almost 100 surgeon has registered, and in whole at present 80%, 80 to 85.
So now we expect 1,000 over there.
Registration was 124, but almost 100, more than 100 has came into hall once for a minute.
Mittal sir, 1,000.
Absolutely.
Thank you.
I'm with you.
Thank you.
Mittal sir will be the president in 2025, I think.
Yes. But I will take it when the conference finishes.
Next lecture is laser in bilateral sinus.
If you have bought a laser machine to do bilateral sinus, you've done a good job. For fistula it's not good, but for bilateral sinus it's absolutely good. Then you will say, I only do one bilateral sinus a month. So what is the point buying the machine? But if you start doing it, you will see that one becomes 2 a month, then 4 a month, then 10 a month, because all those patients start telling other people, and you suddenly gain momentum. So I'm going to be talking about minimally invasive surgery, that is laser in bilateral sinus. Okay. Now let's have a look what it looks like. So you have the secondary opening, then you have the primary pits, another secondary opening, and then you have these hairs. See how the hair is going inside? And when you increase the size, that's how the hair is going in. And you must understand that this is the normal skin. What you see is normal skin. All our skins are like that. This is under electron microscopy, and that is the hair going inside. And you see the lines? They are scales. Hairs can go in but cannot come out. These scales prevent the hair from coming out, and the hairs are sharp like this. Now what is happening is a normal follicle becomes a stretched follicle, infected, acute abscess develops, chronic abscess and epithelial tube develops. So you are dealing in this stage, and then you have to mark out where it is. Are they in midline, that is pits, and the others which may be in midline or outside in the navicular area. So you have to mark it out to decide what to do. So this is the most complex classification, Tessel's classification. It shows you what type it is and what you should be doing. Now less is more is a worldwide concept. It is accepted. It's time to abandon open radical excision and flaps as the first line of treatment. So pioneer surgery is essentially excision or no excision. If you excise, then you leave it open to heal by secondary intention. It could be suturation, musculation and VAC. If you do a primary closure, you can do midline or off midline. Midlines are bad, don't do it, they open up. Or you can put a flap, which could be Limburg, Bascom, Caridacus, VY, double V, C, D, all types of flaps you want to do. And no incision is basically minimally invasive. So one is defining, which can be done in the smallest city of Surat, right? Where only one surgeon is there, you can do it. Because you don't require anything, you just require a punch. Then EPSIT, that is endoscopic bilateral sinus treatment, and laser. So what happens, how many people are doing flaps in bilateral sinus? Okay, so I'm sure you must have come across patients like this. These are all my patients who have come for minimally invasive surgery. 3 of them are doctors. This is Bascoms and Limburgs in one patient. And this was Limburgs, closure in midline, double V plasty, Z plasty. So when this occurs, patient has been immobilized for 3 months, and then finally when the patient is mobilized, you see it's occurring. And imagine the state of the patient. The patient has not been allowed to squat or sit on the floor for these 3 months, and they have a problem like this. That's where the idea of doing a minimally invasive surgery appeared. And if you do minimally invasive surgery, you can evaluate, think and choose wisely. Now look at this. You see the openings. This is a simple opening you see. But have you noticed that the hairs you take out are longer than the hairs which are here? See this hair? See how long it is? Look at the size of hairs. And the surrounding skin hairs are small. These are occiput hairs, and they are embedded inside. they fall off and they go to the nasal cleft, and when the patient is sweating, they embed inside. Then they say you got to do flaps because you want to flatten it. This patient has been operated 3 times, once in Delhi and twice in Netherlands. I look at the status, and when I measured it, the depth was only 1 centimeter. This is how you measure, one horizontal and vertical. So what are we saying that we need to create a flap? You really don't need to create it. You need to take the hairs out. You need to clean the area. You need to take out the fibrous tissue and unhealthy tissue and heals up. So we have Trepine, EPSET, laser, EPSET plus laser. Now, these Trepines cost 150 rupees, available in Amazon, various sizes from 1 millimeter to 10 millimeter. 10 millimeter any 1 centimeter. You see the size of the hole. What is happening is when we use the blade may cut down, but they may miss some part of this tract. And you think you have cut it, but you have not actually cut it. If you use this, it will come out completely. Then you can say you have angled it wrong. Yes. So what you do is, through this you put a probe and put that probe inside this tract. So it will go towards the direction of the tract and then cut out. So it comes out like this. This is the epithelial tissue which has come out. So what Dr. Gibbs said, and which you can do in a small village in India, is this is the tissue, pyramidal sinus. He said, why are we taking out the healthy tissue? Why don't we just take out, you make a hole, that's the hairs, you have made the hole, you have taken the hairs out, you have cleaned it, and it shrinks. So what was done was pre-op, post-op, 2 weeks, 4 weeks. So they have a success rate of 83%, which is remarkable for a procedure which takes 10 minutes. Now, taking that forward, how can we do that in laser? So you've got this patient, you made the marking with marker pen, and methylene blue you may want to put it. I don't usually put it when I'm doing laser. And then you use the probes according to the size of the hole. So here you made with punches, you made the various holes. And this is how it all comes out, right? Then you put the laser fiber inside and burn the insides. So you have done the laser surgery. The most important aspect of laser in pyramidal sinus is you should not leave a single hair inside. Now, if you have any sort of scope with you, histoscope, pediatric scope, nephroscope, any scope which is small, after you curated everything, after you've taken out all the hairs, we get a brush. I don't know whether you people have seen it. The brush has a central brush, and there's one rod here, and if you do it like this, all the hairs will come out. To see inside, if you have any scope, just go inside and see. You don't have to do anything, you have to see inside. No hairs, then you fire the laser. So after firing the laser, the holes will be shrunken a bit, but that's not the issue. Now, if you're punching it and you have a scope, you look inside with the scope to see this is the laser fiber inside the scope, and then you fire it. Or you can put the laser fiber separately. In a sense, the tract has to be cleaned. The laser fiber, when you're firing it, after you've fired everything, you have to re-clean it. You have to re-curate it. The people imagine that once you pass the laser fiber in the tract, it gives out some solution and it shrinks the tract. It doesn't. All it does is burns the internal layer. So you curate it before, do the laser, curate it afterwards. The combination of this is called VALAPS, Video Assisted Laser Ablation of Pyramidal Sinus. mosquito inside, try to pull out the hairs, then cure it, take out the unhealthy tissue. Then you have the probes. Now I thought it went up to 6, but it goes up to 10. So for this case, if I had to do it again, I would have used 8. Here I'm using 4 and 6. And the small ones with the small punch. You wash it with hydrogen peroxide and saline, dry the openings, then you pass the laser fiber inside. Remember, the radial tip can get dislodged, so you put an infant feeding tube first, and into that you put the laser fiber and pull it out on the other side. And now if it's wide, then you have to do it fan shaped and do it from all the holes. After you do each time, you have to flush with cold saline. And you can close it, do a dressing, and next day you can change it. So when you see the patient after 14 to 21 days, this is the wound, and they heal beautifully. Now valves, in an abscess we say is contraindicated to do it. Naturally, we have to take one step ahead and see is it possible. So this patient had a huge abscess. With the punch, make a hole and aspirate, cure it, put the scope inside, clean everything out, scoop, hydrogen peroxide, and this is the hair which comes out. The length of the hair from here to here is 4.5 centimeter through the palatal sinus. That's how the hairs are. You just grab it. That's why if you have the scope, fistuloscope, you can take it out. See, few fibers which are left. And then you start cleaning everything and you do laser ablation of the tract here. And this is at the end of surgery. See how clean the surgery is. And that's day 1, that's day 3, day 7, and day 10. By 15 days, it almost goes away. And this patient, you will see how tricky it becomes. The patient had 2 secondary openings and 3 pits. And I will do it fast forward. I want to show you how to angle the punch. So this is another way. To the probe you come and the punch goes over it. So you punch out all the spaces, you put in the scope, look inside, take out the hairs, curate the tract, put a probe inside, put an infant feeding on the probe, take the probe out, put a laser fiber into that and put it out. And then on your way out, 10 watts per millimeter per second, you are covering the tract. Do it for all the tracts. That's how it looks in the end. So it has remarkably reduced the operating time and the results. If the patient, the most important part of laser bilateral surgery is you have to curate the tract afterwards. That means take a small curate and curate it, all the dead tissue has to come out. So I invite you all to our 27th instructional course, which is at Prayagraj from 3rd to 5th April, and the exams are on 6th and 7th. I have many people here who have given the exams. You have given the exams. Naresh has given, Bhavin has given, I have given, Nitish has given. Anybody else? FACRS exam.
Long time.
So what I am saying is, once you give it, I'm the patron there. And it's my alma mater, so I'm going to make sure everybody passes. Not because I told PU examiners to pass them, but because I teach you before you give the exam to make your level very high. And once you give it, you feel the difference. So please join us at Allahabad or Prayagraj. Any questions?
Any question, please? So we are heading to our next session. Dr. Bhavin Bua. Sir is going to present a video on laser pyloneedleplasty. Sir is a well-known faculty in Surat with 18 years of experience. Sir has done fellowship in laparoscopy surgery in 2008 in Germany, fellowship in colorectal surgery in Singapore, awarded fellow in Association of Colorectal Surgeons of India in 2017. Sir has academic and clinical experience of 5 years as an assistant professor in GMC Surat. Over to you, sir.
Thank you. Good afternoon, everybody. First of all, I like to thank Dr. Mittal sir to allow us to present a lecture. And Mittal sir was the first person who have insisted us and to promote us in a academic of this anorectal surgery before 3 years. And after that, this is the third conference in Surat on the anorectal surgery. So me, Dr. Naresh and Dr. Siva are the partners and at the Star Surat Clinics, Piles Clinic. Today's my lecture is a laser pyloneedleplasty. Sir has already shown the 2 short videos, so I like to try as per my view and my technique. This is anatomy, already sir has discussed. What is the aims and objective of the laser pyloneedleplasty? This is main to avoid the large flap by the laser pyloneedleplasty. Which cases are the indicated for the laser surgery? Not all, but simple, non-complicated single track are the preferable for the laser surgery. The patient who has a multiple tracks previously operated for the laser and which have raw area in central line natal cap are the contraindicated patient for the laser pyloneedleplasty. These are the requirements for laser pyloneedleplasty. Main is the radial fiber we need. The OT steps are pit excision, hair removal, debris clear, track curated and wash out. After that, laser ablation of the track with the radial fiber and energy should be the 10 watt per millimeter per second with the 1470 diode machine, and cold saline wash, clean and dress. This is a small video
animated video I like to present before the clinical video to understand the better way. This is the video showing the animation of the pyloric sinus with the multiple pit. So this pit excision done and curettage of the tract and the curettage of the pits and the tract. The hair, you can appreciate a bunch of hair inside the tract and like a big cavity inside. So as much as curated done with the and later on the saline wash with hydrogen should be given, so we can clear up the all debris and the hair follicles. After that, the insertion of the laser like this way to ablate the cavity and whole of the cavity in a multiple place, multiple pit, and after that the tract will be shrinkage with the pit. So this is a basic procedure, and after that what we do for the laser pyloric surgery. These are the two sinus, small sinus. You can appreciate this one from the right buttock and other from the left buttock, and the hair is inside the pit. You can appreciate clearly the two hair are inside the pit. This is a secondary opening excision with some part of the tract as much as we can excise through that incision, and better hemostasis should be done. And after the excision, we should move to the another secondary opening and excision of that opening and the small part of the tract. So this is the first step, and the second we should do the pit excision. This is the refined and the multiple pits excision done in midline. As you can appreciate, 3 pit we have excised it, and after that curettage of the tract. But before that we should insert the probe to continue to make sure, and this is all cavity connected to each other, so each and every part should be curated, so no debris or no hair should be remain inside. As sir has already explained, the remaining hair is the culprit for the recurrence of the sinus, and we should make sure that as much as we can do the curettage and removal of the hair with the curettage and the washout of the cavity. So each and every pit and the tract curettage and washout with the saline betadine and hydrogen peroxide solution. So each and every cavity in tract should be cleared from the hair. Next step should be the insertion of the laser fiber. This is a radial fiber, you can see. It is used for the pyloric sinus. To avoid the damage of the tip of fiber, we should insert it with the help of infantry tube, and if there is a small tract, it's okay, because under vision we can do it directly also. And each direction in fan shape manner, each wall should be ablated with the laser 10 watt per millimeter per second. The pit also should be ablated with the laser, and the another track you can appreciate same method should be applied, and each and every wall should be ablated with the laser fiber. And after that, for cooling down, we should give the wash of the cold saline to cool down the cavity and the tract. So this is the final picture, and I like to show another video for the single tract pyloric sinus with multiple tip. This patient is why laser is helpful in a young patient. This patient is a doctor's son, and next March he is going to appear for the NEET exam, and he is unable to sit because of the pain. So this patient, after operation, after surgery, third day he is going to his class and doing his normal activity. So that is the main advantage. And same step should be applied PEET excision. The fourth step one should remember for the pylorus sinus surgery. First of all, one PEET excision to deal with the tract, to deal with the abscess is a third, and fourth is a hair removal. These all four steps are the key steps in the pylorus surgery. And anything violation in these steps should be responsible for the recurrence. As hair follicles must we have removed as much as this patient having a lots of hair inside the cavity should be removed as much as with the partial excision of tract from the same secondary opening we are doing. In all case, in our experience, little experience, less than more than 20 cases we have done last 2 years, and we do the partial excision of the sinus tract also as much as from that opening. This is a bunch of hair and the debris, and same wash given to remove as much as hair from the cavity, and thorough debridement with the scooping should be done. The another few reasons for the recurrence are the post-op care also is as much as important. Proper dressing and to avoid the infection in the cavity or tract should be kept in mind. And the surface, skin surface, the condition of the skin surface also very much important for the better follow-up and for the good results, long-term results. So cavity we have ablated with the laser and natal cleft PEET also in all direction. This is a big cavity. So sometimes what we do that after 10 to 15 days, this all case, not all case, but this big cavity or big tract, we do local anesthesia, scooping and laser after 15 days for the better healing. We do this all patient in the spinal anesthesia at first time, but second time if we need, then we do local plus sedation also. So these two cases I have presented, and for the recent guideline and recent paper few presented, this all supports of the laser surgery for the simple pylorus sinus case. I like to show. Thank you. Yeah. We have found few papers in support of the, and this is the original article, effective and considerable treatment of the pylorus sinus disease in laser ablation. And another, this journal of Proctology, laser pylonotomy new approach, and third is this lasers medical science journal, laser treatment and pylorus sinus, a systemic review. All are very supportive in for the laser pylorus sinus surgery in a simple pylorus sinus tract with good results, good less hospital stay, and early to work, and less operative time, less hospital stay. So it is concluded is if patient having a simple pylorus sinus, chronic pylorus sinus, not with abscess, then one should go for the laser pyelonoplasty surgery. And our small experience of more than 20 cases are, we are having 2 recurrence only, and 2 patient has lost follow-up. Rest of the patient has treated well. Especially we got NRI patients. They come for this surgery and they have less period of the time and heal well in a short period of time. So this is good for the students and those type of patients who have less time. Thank you very much. Thank you.
Thank you.
Any question?
Any question?
So there in Indore, some paper also there. I don't have a paper. Okay, there is no any added advantage because some autopsy finding also suggested that the hair of the back and hair of the head scalp also found in the pulmonary sinus cavity. Thank you. But if patient is affording, we advise hair removal. If not, then we can say that it's okay. Every 2 weeks saving up to the 2 to 3 months, we should do that to avoid the recurrent.
Hair removal is not necessary, but till healing you need the hairs out. So instead of shaving, you do clipping. Depilation is also bad. Patients come with full burn, chemical burn of the back. They've tried anti-French and all those things and it's reacted. Whole back is red. So clipping, you get very good clippers. They cost 1,500 rupees and they take the hair out. Only small stubs are there and that is okay. So somebody can do it. It's very simple to do. Anybody can do the clipping.
So then what about the occipital hair?
You should become bald. Then only you'll be okay.
So our next session is for complications and it's the last part. So I like to invite Dr. Harish Chauhan and Dr. Nattu Kataria to chair the session. And this session is for complications of laser, do and don't in laser. So I welcome Dr. Mittal sir again. Up to you, sir.
If you are sleeping, I think this lecture will wake you up. As we know, first do no harm. And what has happened with laser is, people are buying it, thinking they'll be overnight success. The patients will have minimal pain. There'll be a long list of patients standing outside the clinic door when they go to the hospital. And it turns the other way around. There is a police standing downstairs that you have created this problem. And the problem is only because you didn't get trained or you had over-enthusiasm. You know, the book says this much energy, I think the patient needs more. And that more energy is what is causing the problem. Nitish, apna wo de dena. So the question is it the laser machine which is causing the problem? Or is it the person behind the laser machine which is causing the problem? And I think you know the answer. So the commonest ones, it gets worse. On the table, if you see a problem, then that is only 10%. On the table, if you see it, it's only 10%. Everything else occurs later because the problem you see on the table is just the burn. But the depth of burn comes later. So the patient can have non-healing wounds. Patient can develop abscesses, gross edema, severe pain, doesn't go away with anything you give. Lot of sloughing of the anal canal, sloughing of the ulcerations, stenosis of anal canal because you've given too much energy in healing with stenosis, incontinence because you have burnt the sphincters, and perforation if you have gone very high. So this is gross edema due to excessive energy, and we were trying to chase the hemorrhoid size. Nothing happened, but they became bigger than they were. They're bigger than what you started with. So play it cool. Just regular ointments, soothing ointments, and seeds bath or ice packs will do the trick. You have to wait for 3 weeks. Too much energy per hemorrhoid. As a result, the sphincters gave way and the patient comes with frank incontinence. It was either because they were chasing the hemorrhoid size, or the laser was in the wrong plane, or there was bleeding and they tried to stop the bleeding with laser. Again, a different patient. These pictures are from all across India. Most of them are pictures from my students. And see the depth, see the yellow canal, and see all this big mess which was made was laser hemorrhoplasty. Then where you enter the laser fiber, as in fissures, they become abscess and they don't heal. So you have this permanent feature there and you have to take it out. Then laser-induced iatrogenic fistula, which was not there, and like you did fissure and it punctured, or you did hemorrhoid, it punctured, and that becomes a submucosal fistula strap. Bleeding and burning when you're using the laser wrong. This is secondary bleeding and you thought everything was okay, and see the amount of blood which is coming out. Truly tragic. Abscess with mucosal necrosis here. This is because too much energy or wrong energy or the mucosa being cut through. We don't know. But the most dangerous ones are this one. This picture, see this? See this. The energy given was over 1000 watts. They died. So much energy given, patient went into septicemia, colostomy was done, stayed in ICU for 2 weeks and the patient died. It doesn't help. Then you have laser iatrogenic fistula, which is not there, but you created it. And excessive energy, this wound gives way. So you have to be very careful with lasers. Mucosal burns, this one I just downloaded. Thank you, Parth, for giving me so many pictures. Now this is a colonoscopy in a patient who had undergone hemorrhoidoplasty. See the circumferential burn. Now tell me what is going to happen when the patient heals. Stenosis, stricture. He'll be absolutely closed. And we are doing this. My main motto when the Naresh called me was selection of machine and complications. And if you have any patients from other surgeons or your own and you have complications, please send them to me, because I want to go across India and to make surgeons aware that these can be prevented. Don't do it, that it becomes so bad. Look at this. What is left? No mucosa is left. And I'm going to be very sure there's going to be total closure. And the patient will need a big procedure to get through this. So it could have been avoided. Laser iatrogenic fistula. See the tract going up. And this was because small thing was supposed to be done, and then the tract kept going up and gone above the levator. Now this one I want you to read. 1 year back, a 56-year-old female underwent laser anal fistula surgery by a senior doctor. Now this is Gujarat. We don't know the city, but it was circulating in Ahmedabad. No perianal suturing was done, only laser energy had been given. Post-op day 3, patient referred to higher center as she had a rectovaginal fistula. Patient went to private medical college and colostomy and refashion of the fistula. She became septic. Post-op day 2, admitted in ICU with rectovaginal fistula. Then patient went down. After 7 days, she was admitted with multi-organ dysfunction syndrome and died on day 2 of readmission due to irreversible sepsis. Now she only went to get a laser fistula surgery done. And I presume she had a Phylac, which was, I'm telling you from now that Phylac doesn't work. So if you give too much energy, you are destroying various planes, and if you go too high, you're in the wrong plane, and this is the end result. And it's not only one. We see lots of cases like this. Now she died, but the ones who don't die, they come to Mumbai. Dr. Pravesh has many, I have a few, Niranjan has a few, because these patients are circulating. They don't know what to do. And I would put the cause as surgeon related and patient related. Patient related because patient demanded. Surgeon related because surgeon didn't refuse. If you think it doesn't warrant, then don't do it. Don't do anything which is not warranted. Look at yourself. I can do this, and I think this will help the patient. Do it. If patient says otherwise, tell the patient, I'm not doing it. Please excuse me. You go to somebody else. So you have to be you have to talk to your patient. You have to tell them what's going on. Tell them what are the possible outcomes. And never, you use laser, less amount of energy, at least patient will have a recurrence. But patient will not have a bad complication like the ones I've shown you. So primum non nocere, first do no harm, Hippocrates. Now can we reverse this? Yes, we can. When things go wrong in laser hematoplasty, you have complications, you assess the patient, you examine the patient, make a diagnosis, manage the patient, it's complete relief. But it can be sepsis and death. And I've shown you 3 deaths after hematoplasty. So the problems are related to instrument, laser machine and fiber. Laser machines means using 980. Fiber means using bare fiber. Related to procedure, intraoperatively or postoperatively, how it was done. And the doctor was not trained in laser surgery. Now, one of the things I tell you, so you don't use too much energy. Nitish was very kind he was doing a case yesterday. I said, I need to send a message to people. When you are doing laser surgery, one eye has to be on the monitor. And the monitor should display big letters. Any machine which has small letters, don't take it. So see the size of that. You can see that what is the wattage and what is set at and the number of joules being given. So we'll now see. You have the joules here, total number of joules, and the wattage here. These two readings, this has to be set, and this is you have to keep track. The moment you exceed this, now exceeding means in hemorrhoids 150, in fissure 100, 120. But in fistula, ये बंद कर दो, आग लग जाएगी. भूगना मत, हाथ से बंद करो. ये लेजर का होता है एक स्पार्क से इतना बड़ा होता है. Now see the letters. They're nice. I don't use laser cloning, but I saw this when Nitish said it was, and even for neo laser it's big. I mean all machines which have big displays. Sometimes the fiber gets stuck. You can't unlock it. Call the service engineer. Don't tamper with it. Don't open it. If you do, you may break the port, and you know how much money is going to cost after you break this port. Everything has to come from the country of origin. Laser machine does not fire. Now this is a common problem. I was doing a case day before yesterday, and my routine OT boy didn't come, so the Mosi took over, and she knows everything. And I kept pressing the pedal and nothing was happening. I said, you have put the wrong port. We took it out 3 times, 4 times, shut the machine off. But my right feet was pressing it, which was attached to cautery, and my left feet was where the laser was. And I was pressing the right. Then she said, sir, you're pressing the wrong foot. So please see, is the foot switch locked? Are you pressing the wrong foot pedal? Sometimes you can burn a lot of things by pressing the wrong, because the cautery wire is there and the laser is there, and the laser you kept on top of the patient. You're pressing the laser machine thinking you're pressing the cautery. So please remember, fix I fix left leg for laser and right leg for either monopolar or bipolar quadrilateral. Then fiber tip breaks, we have already had a long talk. So the things we asked was, Dr. Jawar gave his experience, you can remove it, how you palpate it and you just take it out. Then I talked to other people. Some people said, just leave it in. It's a small plastic inside. If it causes a foreign body reaction, it will come out. Don't panic. There are so many people in the army who have so many bullet sharpeners in their body, nothing happens to them. So it's okay, don't panic. Or you can do a hemorrhage. Now why it happens is, you've used the fiber several times. But that's not the problem. The problem is when you clean the fiber, you make it loose. And then when you insert and you put it out, it goes inside. So we'll talk about cleaning. So you got to clean it, use hydrogen peroxide in a gauge piece and clean it. But how do you clean it? Now this person who is cleaning it, he's showing you the exact thing. Hold the tip, not the fiber. Hold the glass tip and hold it like this. And then clean this on top. What we would do is, we would do it like this. So you are moving the glass and you are moving the fiber. But if you hold the tip, just watch. That's hydrogen peroxide. At no time that tip is left. You get it? So if you want your fibers to go on long, you have to make sure you are holding on to the tip. And once you hold the tip, nothing will happen. Then, how much should you roll? So you should have at least 6-inch circle. If you do shorter, then it will break. So perioperative complications, technical glitches during hematoma formation after HGHAL, just like stapler, you just have to press it or take a figure of 8 stitch, 1 centimeter above. Or if it's uncontrolled and it's becoming quite big and alarming, then take cutest stitch. If it stops, leave the hematoma alone. Don't do anything to it. Bleeding at the point of entry of laser fiber. So you have entered either for fissure or laser hematoplasty, and you see when you exit that there is bleeding, and then you press it for a couple of minutes, press it for 5 minutes, bleeding should stop. If it doesn't stop, what I recommend is you take a bare fiber and put 1 millimeter of that bare fiber in that hole where it's bleeding from and fire for 2 seconds. It will stop. It invariably stops. If it doesn't, then you can put a figure of 8 stitch with Vicryl 20 or 30. Post-op complications. Pain is a big problem because the area you have done laser hematoplasty becomes dry. It starts itching, and because of the dryness, the pain is there. So what you need to do is either give a pudendal block when you are operating and finishing, and put a diclofenac suppository just as you finish your case. This is where it's causing a problem. And pudendal block, as we all know, a perianal 10 ml, and on each side you give 5 cc each to block the pudendal nerve. What are you using? Bupivacaine is good because it is long lasting. You can also add methylene blue, and you can also add hydrocortisone. Edema after laser hematoplasty like this. Do you do anything? Well, initially manage with cold compress and then seeds bath. Flavonoids, as I told you, 1000 milligram thrice daily, then BD, then once a day. And enzyme preparations like glutathione, formalin and trypsin, that will help. Burning and itching after laser hematoplasty. It leads to dehydration of mucosa. A local application of sucralfate metrogel to keep the mucosa moist, and antihistaminic. Thrombosis of external hemorrhoid. This was asked. Okay, what do you do with the external hemorrhoid? So wait and watch for 24 hours. If patient still complains of pain, excise it under local anesthesia. Delayed bleeding in the post-operative period. So you look for the cause secondary to infection, or is it sloughing of mucosa? Now that patient you saw, it was sloughing of mucosa. So balloon tamponade can be done. This is a balloon tamponade. That means you take a Foley's 20 to 24, fill it with 20 to 40 cc saline once you put it up above the anorectal ring, put a traction and stick it to the thigh. And after 24 hours, open it. Or you can do transanal suture hemorrhapexy, that is Jutin stitch, or spray of thermal energy with bare fiber, if it helps. Abscess formation after laser hemorrhaplasty. That's the abscess. Due to mucosal ulceration due to injury of mucosa, do proctoscopy, assess the cause and treat accordingly. Drain any collection which may be there. Skin tags, they may be there. They could be external hemorrhoidal tags. So you can excise them under local anesthesia. And this is the recommended dosage. One of the things we don't want you to do is enter through the intersphincteric space with the bare fiber and go to the hemorrhoidal tissue, or laser spray on the mucosa, which both don't make sense. Yet people are still doing it. So preventing a complication, what not to do, never try to push a fiber against resistance. If it's going against resistance, that means you are in the muscle. Never activate if the light is too bright, that means you are too superficial. If bile mass does not shrink, do not keep giving continuous energy. So again, to remind you, these books are there. Some people have it in the audience, and I got wonderful feedbacks from it. Thank you so much. Okay, I think complete हो गया मेरा. नहीं अभी क्या बचा टॉपिक? 4 टॉपिक तो हो गए और एक.
Any question or?
Good afternoon, sir. Parth, thank you for your slides on complication. He was the one who sent it, and he's not sent it like one day. He has been collecting for the last 1 year. So that's why I'm saying, if you have it, please send it so we can train other people. Yeah, tell me.
Sir, I've been doing tutoring since a while. I've seen some patients do have this tenesmus, it bothers them a lot. Whereas there are some patients whom it doesn't bother much. So is it something wrong that I'm doing?
Yeah, you're going in too deep.
Too deep in those?
Internal sphincter muscle too deep.
Okay.
If the full internal sphincter muscle and some fibers external are going in, you know it's only 3 millimeters internal. So then it causes tenesmus when you take the external sphincter. Internal sphincter लोगों को तो कुछ नहीं होगा. External sphincter के कुछ भी फाइबर आएगा tenesmus होगा.
ठीक है, मतलब bite
पर
Okay, thank you.
Sir, next literature वगैरह
मेरा नहीं है पंचदेश का.
Everyone please fill up the feedback form. Feedback form is there in kit, and please fill the form and give it to at the registration counter.
ફીડબેક ફોર્મ ભરશો તો નેક્સ્ટ ટાઈમ થોડું વધુ સારું આપવાનો પ્રયત્ન કરશું. સારું લખવાની જરૂર નથી, ખરાબ લખશો તો વધારે ગમશે. I think this is a last lecture and short one, and but still so much presence in the hall with at the end of the CME also. So thanks to both of the speakers for the interesting lectures delivered you have.
Thank you so much. See, if you look at the literature, and when Naresh and Bhavin, they told me that we have to include this particular topic in this session, I was searching for literature on laser, and I was actually feeling lucky to be practicing in India. All of us who are sitting here are practicing laser, and none of the guidelines are giving a recommendation that we should be using it. Still, we are using it at our free will, and there is no legal implications of it. But if you look at the literature, the randomized controlled trials are missing. We don't have a large data. We don't have any standardization. Whatever we have learnt we have learned by doing these mistakes or from others' mistakes. We saw Kushal sir's lecture. There are so many things which are happening because people are completely unaware. And most of the time when the thing looks simple, your chances of going wrong are always high. Because you see one, you do one and you start teaching one, the laser looks so easy. So if you look at the literature, what is available today, latest from 23 to 24 now, if we see the use of laser in hemorrhoids as a standalone laser hemorrhoidoplasty, it is not recommended still. There are talks about the financial viability. Fortunately, in India, we are not directly worried about the economic burden of a particular technique in treating patients because our healthcare is not being funded by government. So if you are in NHS or any other country where it is being funded by them, they will have to look at the cost effectiveness also. So this is one of the studies where they have collated the data from around 12 studies and they tried to reach to some conclusion. But this particular technique as per them is most for the comfort of the patient rather than for anything else. And if the cost effectiveness has to be worked on only on comfort, then definitely it doesn't make sense. The second thing, like we were raising issues about the circular hemorrhoids which are being treated by laser now, because our patients, they come and insist that I want laser only, in spite of breaking your head with them that this particular technique is not good for you, you should go for stapler, they will still insist on laser. Now luckily we have chip test procedure and sir's contribution is immense, and now I see not many papers coming on that. Maybe around the last paper which was published, I think it had around more than 5,000 cases. So if we have a confluent hemorrhoid, still we can do a stapler hemorrhoidectomy on that. So if you see the data here, if you compare, the blue thing is the stapler hemorrhoidectomy, and you can see the pain is definitely more in staple hemorrhoidectomy. The bleeding is more in laser. Now laser, we are promoting it as bloodless, but if you look at here, the bleeding is more as compared to stapler. Incontinence, definitely there is no chance of incontinence in laser because you are not disrupting the sphincter complex in any way. And if you are careful with the amount of energy you are giving, that definitely logically that is zero. And recurrence also is much higher in laser group. Now this particular study, it is based only on laser. It has not been done with chip test, so probably the incidence is little higher. In our part, we are doing with chip test, so maybe our data is little different from that. But the problem is that we don't publish our data. And as I say it, I myself am guilty of that we don't publish our data. We just keep on doing cases. We are more involved in doing our practice rather than doing these activities. So there is one registry which is still open where they are trying to find out the effect of laser in fistulas. That particular RCT is going on, and probably when that comes out, we will have some concrete evidence to suggest that whether we can do this or not. Again, there is a small study where they have studied the effect of laser on hemorrhoidal disease, and the same thing, early recuperation, the comfort of the patient, and fast recovery is the only thing which is coming, but the long-term results and other things are still missing. So we really can't conclude anything based on this literature as of now. And this is one study where Mittal sir and Dr. sir, they were a part of it, and they have done these 3 techniques. 5 like we talked about. So when you look at the long-term results, it is not holding the test of time. The other thing that DLPF with Mittal sir shows is probably the one which has got promising results now. Mittal sir, correct me if I'm wrong in that. So the initial experience of the newer technique, and these literatures usually are coming from Nigeria, Iran, where they are still doing filing and reporting success rates. But if you look at the overall data, filing fails in around 86% of the cases. The success rate is somewhere between 14 to 16%. So it is definitely not the way to go. If you combine it with something like lift or slot as we discussed or PF as we discussed, then that data right now is not robust and is missing. So we have to use our wisdom to decide upon what particular technique we are going to do. Important development is in the field of treatment of pyronidal sinus. Now we saw beautiful videos, Mittal sir showed it and Bhavin also showed that. So pyronidal sinus is one such disease where these young people are suffering, and that is where it is also coming in the recommendation now that the laser treatment can be offered to these patients as a first line of management. Because when you do flaps, still the risk of recurrence is there, then why not do laser first? So this is one particular of all the things. If we see, pyronidal sinus is the one probably where the use of laser is being recommended by most of the studies which I could find on internet. Now they had a meeting in Berlin recently, sponsored by Biolitech I think, and the main area of concern was this only, that there is no standardization, there is no guidelines, and still we don't have a large database to conclude how to use laser, for which procedure we can put it, and in which guidelines we can put it for. So right now, if you ask me, if we look at the review of literature, we don't have anything concrete to offer. So probably whatever we have discussed today, take your precautions and then only include it in your practice. Thank you.
Thank you, sir. And before we completing the CME, I'd like to invite Dr. Vimal Vyas for vote of thanks. If any question from the house? Any question?
Thank you so much. On behalf of the Association of Colon and Rectal Surgeons of India, I would like to say thank you to Nitesh sir and Mittal sir for giving us your valuable time. It was very thoroughly, to the point, very much important, small, practical points which we have to utilize in our private practice. Apart from this, I would like to say thank you to South Gujarat Surgeon Society and Star Surat Piles and Colorectal Clinic Surat. Apart from this, I would say thank you from all of us to the Sunshine Global Hospital and all the staffs who each and every time help us a lot. I would like to say thank you to all the sponsors, including LDM, Abbott, Ekta Surgicals, all the sponsors, and last but not the least, the presence. We can say that even on the tea break, nobody was outside. So thank you so much. Thank you.
बंद करूँ
डबल सीन चला